We are live.
So, good evening, everyone, and I will ask Dr. Bhavna to initiate the session and say a few words on behalf of AIOS, and then all the speaker will come. And
Yes.
what I want to share, one thing, just post-COVID in eastern part of our country, we actually see a lot of viral keratitis. I do not know the others' experience, but post-COVID, we see a lot every day, 8 to 10 new patients every day. So that is actually, maybe we can discuss later on. So with that, I ask Bhavna to say a few words, and then Bhavna, please go
Yes, sir.
ahead.
Thank you, sir. And on behalf of All India Ophthalmic Society, today I take this pleasure to welcome all of you, all the audiences, to this webinar on viral keratitis, which should be a case-based webinar. And it has been under the mentorship of our president, Dr. Samar Basak, sir, and Dr. Santosh Onawar, sir. So viral keratitis is not only a disease which cornea specialists are coming across, it is a fairly common entity. So it is important to all the practicing ophthalmologists as well. So that is why this webinar today was structured with all the topics of common interest. And we have got the experts from all different centers of across the country. So we welcome all our experts on panel today. And also I take this pleasure to introduce our experts and panelists today. For the chairpersons, we have Dr. Samar Basak, who's the president of All India Ophthalmic Society. He's also the director and head of the cornea services at Disha Eye Hospital. And we all are aware of his expertise and his being a prolific surgeon. Welcome, sir. We have Professor Titial, sir, J.S. Titial, sir, who's the vice president of AIOS and also the chief of Dr. R.P. Center for Ophthalmic Sciences. In the panel, we have, as expert panel, we have Dr. Uma Sridhar, madam, who is the, let me have my spectacles. Yes. Can I have this?
Yes. Dr. Repti, actually, Repti is there. She is heading the
yes.
cornea unit.
Yes, yes, sir. So also we have Dr. R. Revati, who's heading the cornea unit as at Shankar Netralaya, Chennai, and she is known as yes, she is
Coimbatore. Revati is from Coimbatore, Aravind Coimbatore. She is heading the cornea and refractive surgery. So you have some.
I am sorry, sir.
It's on the screen.
Yes, please share the screen. Yes,
that will be better.
She's the chief of cornea and refractive surgery services at Arvind Eye Hospital, Coimbatore. Next slide, please. For the moderators, I would be moderating the session. Dr. Santosh Onawar and Dr. Manoj Mathur would be joining shortly. Yes, the panelists, we have a very eminent expert panel today. That is Dr. Uma Sridhar, who's a senior consultant, who's the cornea services of Eye Hospital at Noida. Professor Vanati, M. Vanati, madam, who's the editor of IGO and professor of ophthalmology at Cornea, Cataract and Refractive Services, Dr. R.P. Center. Dr. Manisha Acharya, who's the senior consultant, cornea services at Dr. Shroff Eye Center, Eye Hospital, New Delhi. We have got Dr. Vijay Sharma, who's heading the ophthalmology department at AFMC Pune and also a cornea specialist. Next slide. We have Dr. Chintan Malhotra, who's the professor of ophthalmology at PGI Chandigarh. Dr. Rakhi Kusmej, who's the professor of ophthalmology at RIU Patna. Dr. Praveen Dhanpal, who's the senior consultant, cornea services at Ratan Jyoti Netralaya, Gwalior. And Dr. Pratik Tiotia, who's a cornea consultant at Center for Sight, New Delhi. Among the eminent speakers, we have Dr. Radhika Natarajan, who is the Senior Consultant Cornea Services at Shankar Netralaya, Chennai, and she would be speaking on common practice concerns in viral keratitis. We have Professor Amit Gupta, who is the Professor of Ophthalmology at PGI Chandigarh. He would be speaking on epithelial keratitis and viral infections, clinical features, diagnostic differentiators, and pearls in management. Professor Ritu Arora, who's the head cornea services at Shroff Eye Center, New Delhi, and she would be speaking on HSV stromal keratitis, Taming the Brood. We have Dr. Anubha Rathi, who's the Consultant Cornea Services at LV Prasad Eye Institute, Hyderabad, and Professor Radhika Tandon. She would be speaking, Professor Radhika Tandon, who's Head of Cornea Cataract and Refractive Services at Dr. RP Center, AIMS, New Delhi. She would be speaking on surgical options in management of post-viral vascularized corneal scars, and myself, I would be speaking on herpes zoster clinical spectrum. So I heartily welcome you all today on this webinar. And I apologize for a bit of confusion in the beginning of the session. So viral keratitis, as we are aware, is one of the most common entities in clinical practice, and it is most underdiagnosed. It is a great mimicker, and it can mimic various infectious causes as well as non-infectious causes. And because it has got multiple presentations, that can be challenging to the clinicians. So today we will try to simplify the approach in diagnosis and management by way of practical tips through this case-based deliberation. And we shall endeavor to provide simple answers to all queries that you would want to know. And in this session, first we will have all the topics covered by the speakers, followed by panel discussion towards the completion of all talks. And I request all the audience to submit your questions, comment, or any other observation in the interactive box. We would be very pleased to address it with the opinion of our panelists and experts. We start right away and hope to have an insightful session with you all. So the first speaker for today's session is Professor Radhika Tandon, madam. She would be taking surgical options in management of post-viral vascularized corneal scars. Over to you, ma'am.
Actually, have we changed the, sorry to this, the program says that it will start with Radhika Natarajan, and then there are other talks, then Radhika Tandon. Am I right, or any request from Radhika?
Yes, sir. There was a request from Radhika, madam, sir. She has to leave early for some official comments.
Oh, that is fine. That is fine. No issue. No issue. Oh, Radhika Tandon, then, please. There are two Radhikas. That's why that is. I have a confusion. Like.
We clarified with each other, sir, before the meeting with the Radhikas.
That is the confusion of HSV keratitis, no? So when you see dendrite, then it is zoster dendrite or herpes simplex dendrite. Similar confusion is happening here.
Good evening, everyone. Thank you, Dr. Basak, sir, and thank you, Dr. Bhavna, for involving me in this webinar, walk-in approach for viral keratitis, walk-in patient. I also apologize to all the speakers for my having to present earlier. But as you have said that this is a very important area, and it is for the entire spectrum of AIOS delegates and members. So I have therefore like to cover a broad overview of the surgical options, also giving information which would be relevant to people who may not be directly engaged in corneal practice, but a patient of viral keratitis, as Dr. Basak said in the beginning, it can come to any ophthalmologist. So it's nice for all ophthalmologists to have a broad idea. Now, pertaining to vascularized corneal scar surgical management related to viral keratitis, I would like to say that there are certain specific nuances that one has to take into account. But broadly, when you have any corneal scar vascular, certain things are common and certain things are specific. Now, as the other speakers will show in the clinical spectrum, there can be variable presentations. And depending upon which stage of the disease the patient comes, you have to curate your surgical requirement appropriately. Regarding the surgical treatment, there could be emergency or urgent procedures where you have to improve the structural integrity of the cornea. So there may be globe salvage procedures, and you will hear about necrotizing viral keratitis and sometimes neurotrophic corneal disorders, etc. And sometimes you have to provide just a scaffold for the tissue to promote healing, as you can have with some neurotrophic ulcers and so on. Sometimes you have to have a replacement of infected tissue because often these patients, the viral keratitis per se reduces the immunity. There's a breach in the epithelium and they get secondary bacterial or fungal infection because of poor hygiene and also the breach in the epithelial protection. And then, of course, the most important thing is once everything is healed up and you have a scar with poor vision, we want to restore the corneal clarity and restore the sight of the patient. So obviously the decision making in terms of case selection, as we know for any other surgical practice, it will depend upon what stage is the disease, what is the severity of the disease, what is the patient needs and handicaps, and what are the other associated problems the patient may be having, either ophthalmic or systemic. And then once you decide that this is going to be taken up for surgery, you can select the surgical technique. And here also there will be variations, and sometimes it is not necessary a one-size-fits-all policy. You have to see depending upon the expertise or the comfort level of the surgeon and the requirement of the patient. And of course, as I mentioned before, comorbidities. Here I'd like to specifically mention glaucoma and other pathologies, which I will go over. So when I talk about case selection, in certain cases, it's a simple decision whether to intervene yes or no, intervene now or later. And then you have to plan, and then you have to also counsel the patient, because often they hear the word corneal transplant and they somehow think that it will be a magical thing, everything will be perfectly fine. So they have to be mentally and also intellectually on the same platform to understand what it entails. And so we have age, the requirement, the recovery, the survival. These are all discussions which are important to have, and also for follow-up. And in a vast country like ours, where there are a lot of corneal specialists, but they are scattered. So we need to also have the other ophthalmologists feeling comfortable to help with the care of the patient, having adequate knowledge to at least know what to intervene and how to help with the follow-up, etc. And then, of course, viral keratitis has a big challenge in terms of the disease pathology and the prognosis and the particular eye per se. So in options in keratoplasty, one point is sometimes with viral keratitis, they have they may have poor ocular surface. Sometimes patients with rheumatoid arthritis may come up with a secondary disease. So therefore, the ocular surface reconstruction may sometimes also have to be taken into account. And generally, we always prefer an anterior lamellar keratoplasty procedure when possible. If necessary, one would go for the posterior lamellar keratoplasty, and sometimes if there is no option, one would like to go for a penetrating keratoplasty. And last resort sometimes can also be a keratoprosthesis. So these are all game changers, because now we have a whole gamut of procedures available, and there's a major paradigm shift in corneal surgery from a simple PK to now a layer by layer customized treatment. And we have benefits, of course, of endothelial keratoplasty, because it is suture, there are no sutures, and all the suture-related complications, both in terms of infection, vascularization, and rejection and all, become less. And anterior lamellar keratoplasty can also be very useful, as I will show with some of my illustrations. So this is something which is very important. Keratoplasty is not without complications. So sometimes, as I'll show you, there's a very slight scar, and the patient is very perturbed that in one eye, the vision is only 6/18. But you have to explain that 6/18 vision without a keratoplasty may be quite good compared to going into a keratoplasty and landing up with several complications which can occur. And the other trouble with viral keratitis is the propensity to exacerbations and recurrences without the surgery, and of course after the surgery. And patients with more than one risk factor for graft failure will have a significant challenge. And as such, an inflamed eye is a risk factor, or even a past history of inflammation, which happens with most cases of keratouveitis. That's a very important risk factor. Plus, you may have a neurotrophic cornea, and of course, you will have vascularization. And so detailed evaluation regarding the specific layer involved. And of course, one would also like to take the context of the supply of donor tissue. So the decision whether to graft or not, and choose a procedure most beneficial for the patient. The usual detailed history and detailed clinical workup should be done. And nowadays, all corneal surgeons will, of course, prefer to have a detailed workup, including the corneal topography, tomography, and naturally posterior segment evaluation and clinical photographs. Therapy, again, I will say that it is very important to stabilize the patient. If they had a recent recurrence, of an active viral keratouveitis or keratitis, it's good to defer the surgery by at least 3 months, and I will say 6 months is preferred. And then correspondingly, the medication has to be stepped up and stepped down, and counseling is required, and you go for the surgical plan. HSV keratitis may often be associated with glaucoma. As I said, sometimes with herpes zoster, there may be additional involvement of lids and adnexa. And the standard procedure in any keratoplasty would also take into account the tear film and the ocular surface. And we also must take into account the visual potential, because if they have had chronic glaucoma, then that may also be a concern. So the treatment modalities, we should be familiar with the indications and limitations and special considerations. With the K-Pro, there is it is a very good option if you have previous graft rejection, or you have a heavily vascularized cornea which has a high risk of failure, such as 4-quadrant neovascularization. But it is important that the patient has to come for lifelong follow-up, and there is a monthly expenditure in terms of bandage contact lens and also the lifelong medication. So this is something which also needs to be discussed. And the comorbidities, not to forget cataract. So the age group which is involved with viral keratitis or going for surgery, usually it is 40 plus population, though you have younger people as well. So therefore, you have to take into account how to deal with the cataract. Whether you want to preemptively remove the lens, whether you want to consider combined surgery, later surgery, glaucoma, and other pathologies, and of course, associated diseases like diabetes, hypertension, ischemic heart disease, and so on. Now, therapeutic keratoplasty is not very often required, but sometimes it may be required in rare cases such as necrotizing viral keratitis or immunocompromised patient, or sometimes, as I mentioned, they come with secondary infection. So in such a case, you will have to go for an emergency procedure, then whether you have to decide whether cataract, aphakic, or pseudophakic, and the high-risk grafts will require further treatment as well. So in therapeutic, tectonic, or emergency surgeries, again, you have to see whether the visual axis is involved or not, how large is the lesion, how deep is the lesion, whether you can manage with a patch, whether you have to do a lamellar keratoplasty or proceed with a full thickness graft. And these are the usual kind of situations where this is required. Sometimes it could just be a desmetrocele where a DALC can be done. And sometimes if it's a neurotrophic and not infected case, then you can even seal the perforation with glue. So the infectious keratitis when refractory to therapy, and here again, as I mentioned, there may be co-infection, so that has to be handled. There may be perforation, there may be scleral involvement. But here a word I would like to mention, that though the eye may look in a very dire strait, but a timely intervention at the right time can prevent the eye from going to a very severe stage. As far as the depth of the surgery, we will always prefer a DALC or an anterior lamellar keratoplasty, because they're retaining the host endothelium. There's an incomplete, though there's a downside that there may sometimes be an incomplete removal of pathogens if, for example, you have a combined infection, and you can sometimes get an interface neovascularization. But the largest thing against a PK is a higher risk of immunological rejection and endothelial failure. So the type of the graft is, you have to consider the size, with the location, where the normal patch or sometimes even a corneoscleral graft may be required if they have a very extensive disease with associated scleritis. So therapeutic keratoplasty can be a salvage procedure, and generally this is something where it may not be very easy for the patient to reach a very far off location for the surgery. So it's something that one would encourage that more centers should be available for this surgery, though it is not easy surgery at all and technically requires a high skill. Regarding the whether the patient has cataract, whether the patient is aphakic or pseudophakic, depending upon the situation, because sometimes you have a perforation, you have a therapeutic keratoplasty, there's a spontaneous expulsion of the lens, patient is aphakic, and then later on you're repeating it with an optical keratoplasty. There you have to decide whether you want to put an IOL or not. If it's a one-eyed patient, sometimes in such cases, one can leave the patient aphakic and they can have reasonably good vision with aphakic correction. And whether to go for the sequential surgery or combined surgery. And when you're preparing the donor tissue, generally with the extremes of age can be used in special circumstances, particularly when you have a therapeutic or a tectonic. And in India, as such, we don't have any age restriction. Usually less than 3 years will be used only for pediatric cases, and we don't get that many viral keratitis who require that level of emergency care in less than 3, though sometimes it does happen, and then an infant cornea can be used. And then the rim, if one is going for endothelial keratoplasty, then associated cornea suitable with that will have to be arranged, and the diameter and the corneal storage medium are all considerations which have to be taken into account. And during the surgery, one has to be prepared for all strategies and all contingencies. So be prepared also with a requirement for anterior vitrectomy and so on. So these are the kind of challenges I want to show. So you can have an excellent keratoplasty, patient is very happy, but then the patient comes back with either an endothelial rejection, or they can come back with a recurrence of their viral disease, and then they have to be treated at the proper time. Similarly, as you can see, this is the case of a secondary infection, and then you can have huge scars like this. Similarly, when you, as we'll have other speakers explaining, if you miss it at the right time and you don't treat properly, you can end up with a very severe stage, whereas if you treat properly, you can restore a clear, pristine cornea, and surgery may not even be required. And again, I would emphasize that surgery for viral keratitis, it comes in the high-risk category as it is. It's not considered as one of the excellent prognosis cases for penetrating keratoplasty. Now, if you have herpetic stromal keratitis and endotheliitis, we know that these are concerned, the leading cause of chronic ocular disease, and a large proportion of our patients do fall in this age group, and I'm sure that is same across all practices of all the speakers. So a positive diagnosis is extremely important, but if you control the disease at the proper time, you can avoid surgery. So it is a chronic disease, and because of the recurrences, the patient may have the disease for several years and then land up requiring surgery. So all records should be reviewed to see what is the medication the patient has been on and what suits the patient, and of course, a detailed clinical examination. So regarding the clinical characteristics, when you examine the patient, when you see the patient, if you have previous photographs of what the acute stage was like and what the current stage is, that is something important. And the general rule of thumb is do not proceed with the elective surgery in an inflamed eye. So if you have features of acute redness, inflammation, even though the patient is very perturbed about the vision, it's important to let the eye settle down, restore the vision, restore the ocular surface, get the inflammation to settle as best as possible, and then proceed. Another point is not all cases of these patients land up with vascularization. You can have stromal scars without any vascularization. And the checking for the corneal sensations is important. And this is going to be another factor which could lead to sometimes persistent epithelial defect in the donor tissue post-surgery. And the other point is that you should look at the pattern of the patient, because if you straight away see a scar and you decide to operate, a lot of people may not be aware that with time, these scars do tend to fade sometimes. So particularly in some of the younger patients. So therefore, straight away planning surgery without trying other optical measures and watching which way the direction goes may not be a very good idea. So it's good to be sometimes cautious. And then you can have bilateral cases, and you can have some examples where the condition looks very bad and a person who's untrained gets this picture after, say, cataract surgery. They may mistake it for a pseudophakic bullous keratopathy, when actually it may simply be a recurrence of or a fresh case of a viral endotheliitis. And then this can be treated and the patient can be restored to a completely clear cornea. The characteristics in such cases are that usually the pattern of the corneal edema, etc., will be uncharacteristic or not matching with the surgery that underwent. It may be at a different location, maybe far away from the wound site, etc. And here again are examples where you may have a stromal disease, you may have a neurotrophic disease, but if treated properly, that can heal up. And then if it is involving the visual axis, yes, one will have to go ahead with an anterior lamellar keratoplasty, whereas otherwise one can have reasonably good vision with an RGP lens and sometimes even other optical measures. So the clinical outcomes can, as you can see from so many examples, which will be shown later on also, is not always very dismal. And sometimes with the surgery, one can do worse than what the patient may end up with by the natural history of the disease. So with that, I would like to sum up to say that surgery in this case is challenging, but the careful workup and careful meticulous care of the patient is important before you proceed with this. And it's very important to get the patient to understand what are the challenges involved in the surgery, and that they should be willing to come for follow-up and continue the treatment post-operatively. Thank you.
Thank you, ma'am, for a very informative talk. And I'm sure that we would be well informed now on surgical management of vascularized post-viral scars. I have one question, ma'am. Like in viral post-viral vascularized scar, what is your regime of systemic steroids in preoperative as well as post-operative period to prevent any graft rejection, ma'am? Because these are cases which are more prone for graft rejection.
Yes. So my protocol for if they have if it is superficial vascularization, it is not the concern. It is if they have the deep vascularization in 2 or more quadrants. Generally, I do not give systemic steroids routinely. I will give topical steroids, and we will give topical tacrolimus over the upper lid. I don't give systemic steroids.
Post-op, for how many days would you want to continue the patient on steroids? What would be the tapering schedule for such patients?
Yes. So 2 things. One is that the oral acyclovir, ideally, I would start preoperatively. So unless the patient is already on oral acyclovir. And the difference I make is that I would give them full dose oral acyclovir after the surgery for 2 weeks and then go back to once a day, which I would ask them to continue for 1 year. Regarding the topical steroids, I would give the standard regime of topical steroids, which I give. If it is high risk, I like to give dexamethasone QID for a month and I give a combination of moxifloxacin and dexamethasone QID for 1 month, after which I switch them to P-lone prednisolone phosphate because it's a clear solution and not a suspension with a uniform distribution of the steroid. So I will give P-lone 4 times a day after that till they complete 3 months, and then I give them 3 times a day till 6 months and then twice a day, and taking care of any raise in intraocular pressure. After 6 months, I would either continue P-lone twice a day or switch to FML 3 times a day. And Talamus, I give 0.1% 3 times a day on the upper lid if they're adults. And if it's a child with a high-risk graft, I give it 0.03% on the upper lid. There are 2 studies reported which have shown that tacrolimus is better than cyclosporin, and topical tacrolimus over the lids is as effective as systemic.
Yes, sir.
No, next speaker, because
yes, sir.
There are 4 more speakers, so you are also taking the audience question. So you have to have some time restriction here.
Yes. Next speaker is Dr. Radhika Natarajan, madam. She will be speaking on common practice concerns in viral keratitis. She would be taking an overview of all clinical presentation, which would be subsequently also be taken by other speakers in the session. So over to you, madam.
Yeah. Hi, can you see and hear me?
Yes, ma'am.
Okay. Thanks to AOC, Dr. Basak and Dr. Bhavna for having me here. I am Radhika Natarajan, namesake of the previous speaker, but I am from Shankar Nitralaya, Chennai. So I have been asked to talk today to you about common concerns in the appearance and management of viral keratitis. Among the viruses, I think HSV is the most commonly misunderstood and most commonly mistreated condition. So I'm going to focus my attention on this particular entity in today's talk and tell you what I have learned from my experience. So we know that HSV keratitis sets up its primary infection, and then afterwards it goes up and stays in the ganglion, and it comes down again and sets up recurrent infections whenever the situation is conducive for it. So these are 2 varieties that we have. The first concern we have about HSV keratitis is the nomenclature itself. It is variably called as dendritic, geographic, necrotizing, interstitial, disciform, and various other keratitis. But it is important to name it properly because the nomenclature, makes us understand what the treatment is. I'll show you how in a bit. So HSV first sets up conjunctivitis like this, and then the virus migrates onto the cornea and it sets up diffuse superficial punctate keratopathy, as you can see in the cobalt blue picture over there. And these SPKs, they coalesce together to form the dendritic ulcer, the picture of which we are very familiar. And it helps to confirm the dendrite by doing a double staining where the base stains with fluorescein and the edge stains with rose bengal. These corneas have reduced sensation, all of which add to our diagnosis. And then once the dendrites also coalesce, they form this geographic ulcer. So far you've had infection of the epithelium with the HSV. And because the epithelium infection is by directly the organism, the treatment is also with antiviral agents, topically most often, systemically rarely in cases of immunosuppression or in very small pediatric patients. Now, when the virus invades the stroma, it seems to invite or incite an inflammatory reaction. So you have this entity of immune stromal keratitis, where the eye is reasonably quiet. You have fluffy inflammation in the cornea, and this is more immune in nature than infective. And therefore, the treatment is largely with topical steroid and a little bit with antiviral agents. Contrast it with this picture, where you have more vicious involvement of the virus in the stroma. You have equal component of the viral infection, invasion, as well as the stromal reaction to it. And this sometimes even looks like a pseudomonas or a fungal keratitis. And here, since both the immunity and the infective nature are equally at play, these patients require therapeutic dose of both antiviral agents as well as the steroid. Now the virus goes into the endothelium like so and sets up endothelitis or keratouveitis, both of which have to be treated exactly in the same manner. So now if you switch back and see, epithelial keratitis is caused by epithelial invasion of the virus, so antiviral agent is the treatment. Stromal keratitis without ulceration is largely immune, so steroid takes an upper hand. Stromal keratitis with ulceration, here I prefer the term necrotizing keratitis. It gives a better picture in my mind. That has equal component of infective and immune involvement. So treatment is with therapeutic dose of both the agents, and like so with endothelitis as well. So the next concern is to recognize HSV mimics. You can have healing epithelial defects which look like dendrites, but if you see the picture closely, this picture comes up only when the epithelium starts healing well. You can see the original defects stippled with fluorescein, and the disease is actually, the problem is actually much better when it starts looking like a dendrite because the epithelium is closing up. Acanthamoeba keratitis can also cause pseudodendrites, but the eye is much more inflamed with hypopyon, and the patient is having severe pain as compared to HSV keratitis. You can have zoster. Somebody else is going to talk about it later, throwing up dendrites. But these dendrites, zoster itself is rarer, usually unilateral, and these dendrites are much smaller. They're tinier and they lack the terminal bulbs, and you may even confirm the disease because of the dermatomal involvement. So this is my poster slide. This patient seems to have what looks like a blepharitis-induced immune marginal keratitis. You can see the lucid interval. You can see the infiltrates against the lucid interval. But then if you take a little keener look at the eye is very inflamed. It is watery. You can see discharge even accumulating at the canthus. Usually, staph-induced blepharitis-related disease does not produce such a suffused eye. This is HSV blepharoconjunctivitis, which is a primary form of HSV. So how do we distinguish? In staph disease, you have dry blepharitis, whereas in HSV, you have inflamed blepharitis. You can see the two contrasting lids in the panel above. In the panel below, you see that the marginal keratitis is also a little tame in staph-induced, whereas in HSV, it's a more vicious ulcer. Why should we know the difference? Because we know in marginal keratitis, the treatment is with steroid, which is the mainstay, whereas that can flare up the infection in HSV. And the mainstay of treatment here is with antiviral agents. So in typical HSV keratitis, when you see the imprint of a dendrite like the upper picture, or like in the lower panel, when you see bilateral scars with vascularization, I think even clinically, we can make a good diagnosis. But the concern arises in atypical cases. So on the left, you see a patient who had dryness, and that was the presenting symptom because the HSV infiltrates the lacrimal gland. Sometimes you can even see subtarsal fibrosis or even minor symblephera, mimicking cicatricial disease. On the right side in the panel above, this patient was diagnosed to have BSK and referred, but the eye was far too inflamed for a BSK, and there was a dendrite hiding, as you can see in the cobalt blue picture. And the picture below, you can see conjunctivitis. It looks a lot like the candy floss of the immune sclerokeratitis. But then this patient resolved, as you can see in the next picture, only with antiviral treatment, which was instituted along with the steroids. So these are some different ways in which HSV infection can present. And this is yet another atypical presentation, which after healing throws up the characteristic steel wool keratopathy, which you can see as a silvery scar in the corneal stroma. When the virus has left the cornea, at least temporarily, it sets up corneal denervation. So when you have a normal healing epithelium, the cartoon that I put over there shows inward healing edges. But contrast that with this patient where you can see the edge is very unhealthy. You have a lusterless base, and this is a neurotrophic cornea. So immediately you have to stop all the topical agents as much as possible. Increase the artificial tears. You can use a tarsography or a BCL. In this particular patient, we have described the unique use of PROS contact lens, as you can see in the second picture, not for vision, but for healing purpose, under which you can see that the neurotrophic keratitis, the epi defect, has started healing nicely. So we spoke about epithelial, stromal, and endothelial disease. But then when HSV recurs again and again in the same cornea, as you can see in this picture, you cannot distinguish clinically at all. Normally, HSV is a clinical diagnosis, but these are the cases when the recurrences mars the clinical picture. You have to institute corneal scraping and microbiological testing. You could do a PCR, which can diagnose the disease, and then the treatment is with both antiviral and steroid. But even then, give the antiviral first, let the epi defect close down a little bit, as you can see in the second picture, and then you can hike up the steroid at that point. So like the previous speaker mentioned, the most important concern about keratoplasty, she's told us the various techniques, but I'll just address the concerns in a bit. The most important concern about keratoplasty in HSV disease is, should we do it at all or not? Because as it was mentioned, this is a disease which tolerates any form of corneal surgery very poorly. So the first patient has got a small heel, viral keratitis scar, which absolutely requires no intervention. The patient in picture B has got prominent cataract with a smaller scar. So you can see that the cataract surgery has done the job in this patient. In the picture D, you can see a little larger scar, but you can see the outline of the pupil very clearly, which means that the patient also has got a view outside. And these are the cases which benefit with rigid contact lens. PROS lens in particular has been able to help a lot of these patients. The patient in picture E, the lipid keratopathy is more than the scar, and we've done treatment for that. I'll tell you in a bit how. And you can see that the opacity has reduced very nicely, making it amenable for spectacle or contact lens use for this patient. But when HSV disease, comes with necrotizing keratitis, which has melted the cornea, or if it leaves behind a large scar, as you see in the picture on the right, then keratoplasty cannot be avoided at all. So what are the concerns before we operate this patient? I'm not going to talk about the surgeries themselves because they were discussed earlier. The concern is that we should know the layers of involvement. For example, you see the patient on the left, it's a wider area of involvement, but if you see the slit picture, you can see that the endothelium is spared. It is an anterior scar. Whereas the patient on the right, it is a more circumscribed involvement, but both the slit picture as well as the AIOS show that the deeper layers are involved, including the decimates and the endothelium. So we need to know the layers of involvement for us to know whether anterior or posterior layer keratoplasty will work, or whether this patient needs a full thickness transplant. Also, the eye needs to be absolutely quiet. We thought this eye was quiet before the surgery, but then staining is very important because you can see bits of dendrites there which are still active, and this eye is still not quite ready for keratoplasty. It has already been mentioned regarding neovascularization as a complication following herpetic keratitis. So we have done some work in which we have shown that fine needle diathermy with appropriate patient selection and at the appropriate time helps in receding these vessels. And then we prepare the eye for keratoplasty when it is absolutely required in HSV keratitis, and we have published the same. And it has also been mentioned that the antiviral cover is of paramount importance. Otherwise, you may do a great job and the graft will only melt to viral disease. Oral acyclovir is good, but better still is valacyclovir, which is a pro-drug and therefore has got better action. So intraoperatively, we know that viral scars can be very variable in terms of their thickness. So it has to be remembered. You see that small innocuous scar over there, but in the blown up picture, you see, it is actually shelf-like. There's a lot of thinning over there. So these things have to be looked for carefully, either on slit lamp or on ASOCT. So we take care about these things during suturing so that we don't have a wound leak. And most often, we don't do a preoperative microbiology, so samples need to be collected. That is a concern during the surgery to establish the diagnosis with these specimens. We keep talking about the scar and the vascularization as concerns in HSV disease, but here you see this patient, the middle two pictures, you can see that recurrent viral keratitis has also caused damage to the limbus. So this patient, in addition to the scar and vascularization, has got limbal deficit. So this patient had to be operated on. So we have supplemented sled bits from the same fresh donor tissue, And we have covered it with antiviral agents post-operatively, and this patient did well, and the bits helped in reepithelialization. This is important because if reepithelialization is retarded, it predisposes to recurrence of the HSV disease. Now, coming to recurrence, we keep thinking that epithelial disease coming back is the biggest problem in HSV. But we should also understand that anything which comes too soon is probably not HSV, because we must remember that the nerves have to grow back to bring the virus back to the epithelium. In the top left, you see a typical dendrite, but in the right-hand side, you see the two pictures with and without the cobalt blue, which show an epi defect. This is not a dendrite because it came on too soon. It just requires a reepithelialization over there of the graft. Because if we keep using topical acyclovir in these, then it can add to the toxicity and delay the healing. Contrasted with the picture below, where you can see a lesion which came on later. It is an epithelial defect. It is straddling the graft-host junction, and it stains with rose Bengal. So the delayed appearance and the location and the rose Bengal staining, this is a viral recurrence. So there it is for you to compare and contrast. Why is it important to know that? Why is it a concern even? Because in an unoperated eye, when you have an epithelial viral keratitis, it does not very easily progress to stromal disease. Those of us who've been treating know that a dendrite doesn't go to stromal disease that quickly. Whereas in a post-operative situation, in a graft, as you can see in both these patients in the top panel and the below panel, what started as an epi defect or as a dendrite in the graft has quickly progressed to stromal disease. And this factor has to be kept in mind while dealing with this particular condition. And last but not the least, you have both propensity for rejection and recurrence in post-HSV graft. Rejection because it is a high inflamed, high risk graft. Recurrence for obvious reasons. So this patient, if you can see in the first picture, came with what looked like a Kudadu's line. We thought it was a rejection first, but on closer examination where the arrow is pointing, you can see that the KPs are spilling on to the host as well. So that cannot be a rejection. So this patient was treated as a full-fledged recurrence with antiviral agents. So any surgery, not just keratoplasty, even cataract surgery, entails that the eye should be quiet for a period of 3 to 6 months, and prophylactic antiviral cover is a must. And conservative thinking would be to avoid elective procedures like LASIK or CXL in these post-herpetic eyes. So it's too short a time. So I hope I have covered many of the concerns, which I have dealt with in my OPD, and hope that was useful to the audience over here. So thank you very much.
Thank you, madam, for this very informative talk and a wide variety of clinical cases of interest for viral keratitis. And I must say that the panoramic, description of all cases with very good clinical pictures.
I have one question, Dr. Radhika.
Yes,
it is
Dr. Manisha.
Yeah, definitely a very, very nice presentation. We are all fan of your viral keratitis presentations.
You are the viral expert over here, Dr. Manisha.
No, just a question that what is your regime for quiescence when you're doing a keratoplasty? Because that's always a question for all the people who are, or all the residents who will be doing keratoplasty in these patients.
Correct. While I don't have a fixed number, I wait as long as it takes. I wait till the eye is quiet. I wait till the staining is negative. I wait till the patient is symptom-free and has told me that, there is no redness. I wait till the vessels regress, and then I take it up. So when I've had to treat a patient with antiviral agent, I take up the patient no sooner than 4 to 6 months' time. But all the time I monitor the patient. I tell him, don't sit at him or her, don't sit at home. You need to keep meeting me every 2 months so that I know that, epithelial breakdown, regression of vascularization, recurrence of the infection, secondary glaucoma, all this is not happening.
So just to add to that, we are doing a study, molecular-based study, and at different time periods of viral keratitis. So maybe we can come up with some levels which may be able to give us a clue whether the eye is quiescent or ready to go for keratoplasty or not. It'll take
certainly. If there is an objective counterpart to the clinical evidence, then that will make it even better for us to decide when to take up the patient.
Yeah, it'll take around a couple of years, I think, but we've got the baseline. So I think we are working on that.
We'll be excited.
I think
Radhika, one quick question.
Just one,
when there is significant corneal anesthesia in recurrent viral, would you like to touch these corneas for keratoplasty? Because often we have seen these corneas will go for recurrent melting.
Correct, Dr. Revati. So in a viral keratitis, the best decision about corneal transplant is not to do that. I think all of us on this panel will agree on that. But sometimes the decision is tougher than that, because if the patient is dependent on that eye or is very adamant about surgery, even very anesthetic cornea, sometimes we need to take it up. So at that time, I do an elective tarsography, either temporary or permanent, on table itself, without waiting for the epithelial healing to happen. Even with the keratoplasty, I do the tarsography. And to get by the immediate post-operative period, I may use amniotic membrane as a biological contact lens. I may do temporary, punctal occlusion, copious lubricating eye drops. And when these eyes, break down in terms of their epithelial integrity, I have sometimes used Pro's lenses in office therapy to, heal the surface as well. So these are some of the, I won't do all of these in every patient, but these are some of the measures I prime the patient about when I take them up when the cornea is very anesthetic or they have epithelial healing issues.
I think, any intervention, post viral keratitis cases are risky. I think
Yes,
people listening to us should understand that even a contact lens use can be, with a lot of caution has to be given to these people, because as Revati nicely pointed out, anesthesia is a major concern. And people may not realize they already have an epithelial defect, and contact lens may not be, patient may not realize, and ultimately will come the melting in these cases. Same holds for a keratoplasty also. That's nicely pointed out by Radhika. I think both Radhikas have pointed out any intervention has to be taken with a lot of caution, and people should understand good workup of these patients are important. If possible, we should go a very conservative management of these patients. But recurrence is a major concern in whatever procedure we do. Basaki is saying something.
Ma'am, there is one question. In one-eyed patient with failed vascularized graft due to HSV, what would be the next management? Would you do FND followed by surgery, or you defer the surgery, or you would do something else for these patients, one-eyed patients?
That's a very good question, because the approach to FND is a little different from unoperated virgin eyes to already operated eyes, because when the vascularization happens in operated eyes, these grafts, even if they have failed, a lot of the time seem to depend on the new vessels for their nutrition. So the rate of tissue melt is more and faster when you do FND for post-graft eyes rather than for virgin eyes. So I would be hesitant to use FND in these eyes, not use it at all, or use it a little cautiously as compared to eyes which have not had surgery. So there we wait it out with topical agents, and then sometimes I do a little bit of intra-op FND. So it's not the ideal thing, because normally for FND you have to do it. You have to wait for the inflammation to subside and the vessels to regress before you take up the patient. But I do a little bit of intra-op FND in the hope of giving some benefit. But to answer your question, I would not be free with FND in already grafted eye.
Thank you, ma'am.
Just one question, Radhika. If these cases of viral keratitis, they have a good endothelium, would you prefer doing a lamellar keratoplasty in the case of the vascularized anterior lamellar keratoplasty rather than going for a full thickness graft?
Yes, sir. That is the example that I showed. The thing is that the endothelial viability is a little difficult to ascertain in these patients. A, because of the recurrences that they've had, and B, because you cannot directly visualize either do a specular count in these eyes because of the overlying scars. But there I find that good slit lamp photography with a slit picture and an ASOCT. I rely a lot on the ASOCT, because in the ASOCT, the scars still allow the light to pass through, and you can see the decimates, if not the endothelium, whether it is intact or not. I, in fact, showed it, during my talk as well. So if I'm convinced that, the endothelium is not involved or the decimates is not thickened, and the overall, the one distinguishing factor is that if you don't have corneal decompensation, these scars produce thinning. But if you have corneal decompensation, the scar is also associated with a thickened cornea. So I use these lateral clues to decide about endothelial involvement. And yes, you can do anterior lamellar keratoplasty.
Yeah, very good point. Thank you. I think we can go to
I
next.
just want to say one last point, that sometimes patients come to you with simple corneal opacity and you really don't know whether it is viral keratitis or not. They may just come with a macular corneal opacity or a summer vascularization. You have a hunch that this patient had a viral keratitis, and you may land up doing vascular, either a full thickness or even a DALC. I've done DALC in 2 of such cases where I felt it was a simple corneal opacity, but it landed up with very severe and very fulminant corneal edema and some kind of a necrosis of the graft later. So maybe that answers, Dr. Tityal, what you were asking.
Yeah, thank you. Thank you. I think we can go to next, Bhavna.
Yes, thank you, madam, for a very informative talk. And now we would be taking our next speaker. We would be speaking on epithelial keratitis, which is also one of the commonest viral keratitis manifestations. So viral epithelial keratitis in viral infections, clinical features, diagnostic differentiators, and pearls in management by Professor Amit Gupta. Over to you, sir.
Thank you, Dr. Bhavna, for making me part of this very interesting session, and also the AIOS. And I'll be talking about essentially the epithelial viral infections, focusing mainly on the herpes. And so this patient, he presented with a 5-day history of irritation, pain, lacrimation, photophobia, watering. And if you take a closer look, and you can see some kind of an infiltration there in the cornea. Also, the cornea appears to be lusterless, and there appears to be an epithelial defect. Now, how would we proceed with this case? I usually like to stain first with rose bengal in these patients. The rose bengal will stain the devitalized cells. And here we can see some sort of an early bulb configuration which is forming. Now, this is a classical herpetic ulcer. And if we look closely, because this is a true ulcer, and therefore the base of the ulcer is going to stain with fluorescein. What is interesting is that in the margins, we have these swollen and dying epithelial cells. And these cells typically stain with rose bengal, and they sometimes give a kind of a negative kind of a staining with fluorescein, which is accompanied by some hyperfluorescence, as you can see in this on the first photograph on the sides. So again, going over it, the edge stains with rose bengal because of the cytopathically swollen corneal epithelial cells at the edge of the ulcer, which loses the cell membrane glycoproteins and thus the ability to bind mucin. And the bed, it stains better with fluorescein because of the loss of the cellular integrity and the absence of the intercellular tight junctions. Now, in this case also, we stained with fluorescein. We did have this, it was a very early ulcer because of the short history. And this did not give a typical appearance, but it did show that a little kind of a bulb, kind of early bulb formation, which is classical of a herpetic keratitis. Also, the patient did have a follicular reaction in the conjunctiva. I think it's a very important point to look at in these patients. Do look at the fornix and see if the unilateral follicular reaction is there. The patient is more likely to have some herpetic infection. So the diagnosis of recurrent herpes simplex epithelial keratitis was made. And within day 3 and day 5, we can see that this kind of a cellular infiltration, it remains for a few days and before the patient heals. Now, some tips for the examination diagnosis is in these patients, very often the corneal sensations are reduced. When in doubt, do check the corneal sensations. Follicular conjunctivitis should be looked for, and also stain with rose bengal first. Why I'm saying this is because sometimes the tendency, especially with the younger ophthalmologists, is they put fluorescein. But by the time we get around to staining with rose bengal, the fluorescein has diffused. And so therefore, the edges of the ulcers cannot be clearly seen. The size of the ulcer cannot be properly estimated in these patients. Another patient presented with history of pain, lacrimation, photophobia, and on a casual examination, we can't really make out much, but this patient does have a very early dendritic, like classical amoeboid kind of a shape, which is there without the ulceration, which is usually seen. Now, we should keep in mind the other causes of dendritiform lesion. Most important being the varicella zoster virus, trauma, especially chemical trauma, and a healing chemical defect following chemical burns is also important cause. Acanthamoeba, in every case, suspect something. Neurotrophic keratopathy. I would like to highlight the role of topical medications. This includes antivirals themselves, beta blockers, prostaglandins. So many of the glaucoma patients who are on prostaglandin analogs, and they come with a pseudodendrite on the cornea, soft contact lens, where if you look at the Teichson's superficial punctate keratopathy, and many other more causes, including viral causes like Epstein-Barr virus and adenovirus, can mimic some kind of a dendritic keratopathy. So if we are looking at the differentiating feature between the zoster and the simplex. So in zoster, as we know, they are like kind of raised mucus plaque kind of a thing, dendritiform lesions, and they typically do not have an ulceration. And therefore, the staining characteristics are also accordingly modified in these patients. Now you can see this patient. Of course, if a patient has herpes zoster, he will have these history of, or he will have these kind of lesions when he comes to you. A classical, so almost like a negative fluorescent staining if you look carefully, and you can very classically staining with rose bengal, the herpes zoster. I think Dr. Bhavna will talk more about it. And this is a patient of Teichson's, again, does not classically stain the way a dendritic ulcer would stain. So we can have these multiple microdendrites in herpetic keratitis, and usually it happens more in case of primary herpes or in an immunocompromised patient or a post-surgical patient than in a immunocompetent individual. Now, pseudodendrites, very important that we know how to differentiate pseudodendrite from a dendrite, but I've already explained the classical staining features. In this case, we can see it's mainly staining with rose bengal, poorly taking up fluorescent. And similarly, this is a post-chemical burns patient. We can see fluorescent take-up, but the rose bengal take-up is very poor and on the, almost central. So this is not a patient of herpetic keratitis. This young girl came with some kind of dendritic lesion, but this was following the trauma with the pencil. Once we asked her any history of trauma, so she said that, there was a pencil which went into the eye. Many times these lesions can go on to a metaherpetic ulcer, which is also an epithelial involvement in herpetic keratitis. But there are many differences, including the differences in staining characteristics. They don't stain very well with the dyes. And also, if you see that the edges, the margins of the ulcers are shallow and clean. They are not like raised and grayish and devitalized as we see in patients with the infectious keratitis. Now, it's very important to keep these factors in mind, which might be triggering or which might be aggravating the onset of the herpetic epithelial keratitis. Why? Because one, the response of the treatment might be modified if these agents are allowed to persist. And secondly, the chances of recurrences are more if these factors are not addressed. So it includes just like a history of febrile illness or exposure to ultraviolet light or heat and sunlight, contact lens wear, emotional distress, other infections of the eye which can trigger herpetic as well, and prostaglandin eye drops, ocular surgery, especially cataract and keratoplasty, and other factors like minor trauma, immunosuppression, refractive surgery. We have all seen patients of refractive surgery who have come up with different forms of herpetic keratitis. The American Academy has also specifically mentioned COVID-19 infection and vaccination, which is something which Dr. Basak was talking about as one of the triggers for herpetic eye disease. And this is a patient of leukemia, and in these kind of patients, we can expect the disease to be more extensive, and we might like to modify a treatment in these patients, which I will come to a little later. Now, this is a patient post-cataract surgery, comes with a little bit of a corneal opacity and some decrease in vision. So on a casual examination, you would not really stain the patient. But sometimes if you really take the trouble to look at the epithelium and stain the patient, you will see a dendritic pattern in these patients, and they respond very well to treatment. A patient post-keratoplasty, it's been discussed, but what I would like to mention is this is the graft-host junction. And if you have a dendritic lesion which is crossing over from, so we can have a pseudodendrite post keratoplasty, but if we have a lesion which like straddles the graft host junction, then it would be more likely to be a dendritic ulcer in these patients. This patient post cataract surgery came with a short history of some kind of an edema. So everybody was diagnosing it as a pseudophakic bullous keratopathy. And we've already discussed that there can be a significant stromal edema in these patients. the epithelium doesn't appear as if it has a lesion, but on staining, this patient did have. So maybe this was an early lesion. So even the base is staining with rose bengal. So it may mimic a metaherpetic ulcer. But in this case, we did initiate the fluorescein, the acyclovir, and within a week, the epithelial defect and the lesion had healed. This patient still has corneal edema and probably has bullous keratopathy. Now, very briefly, if we classify epithelial herpes simplex keratitis, in very early stages, we see corneal vesicles. And later on, it forms in the dendritic and geographic ulcers that I was talking about. And another epithelial manifestation is the marginal ulcers. So this is, one of the patients. So it typically shows as a negative fluorescence. And one of the clues is that there's a decreased corneal sensations in 70% of the cases. So these are almost like a transient kind of a lesions as they coalesce together, and then they lead to formation of a dendrite. So this is one of my patients, very early stage, vesicular stage of dendritic corneal ulcer, and responded well to initiation of antiviral agents. So if we look at herpetic marginal keratitis, now typically these patients have a lot of pain and they're very symptomatic, and they will have some kind of an infiltration, and they do have these blood vessels which are coming right up till the margin of the ulcer, unlike the staph marginal keratitis, which has already been discussed. So some of the facts is that if we look at herpetic eye disease in toto, a vast majority are actually epithelial, and many of them will go on to have recurrences. The heads found an 18% recurrence rate of epithelial herpes within 18 months, but only 3% were bilateral in the heads study. So this is important to keep in mind. You can have stromal disease along with epithelial disease, or you can have epithelial disease which later on manifests as a stromal episode. So all these things can be happening in these patients. And for epithelial disease, investigations classically are not needed because the clinical appearance is diagnostic, and usually we don't require them. I'm sure other speakers will talk more about them. So if you look at the management, there is a spontaneous recovery in up to 50% of the patients, and debridement might help. I personally do not debride these patients. I'm sure other experiences I would like to hear. But they do say that initiate the treatment. Why? One, it decreases the discomfort and symptoms in the patient. It can minimize visual loss. Even if there's a ghost dendrite left at the end of the episode, it can significantly make the patient symptomatic. And the other is that it may reduce the recurrence rate, but there's no hardcore proof to that. Now, if you look at the treatment options, one is, of course, the topical antivirals, which I think all of us are fond of giving. There is a role for oral antiviral agents as well as adjuvants. And depending on the affordability, we can give acyclovir 3% 5 times a day, or ganciclovir 0.15%, which is given 5 times a day. Typically, you can give it till the epithelial defect heals, and then we can give 3 times a day for another 1 week. So that is the usual protocol that is followed. Now, is there a role for oral therapy in herpes simplex virus epithelial disease? So, one, in a patient who's unable to instill topical medication, especially children. Also in patients with contact lens fair, when there is doubt between a geographic and metaherpetic ulcer, because in that case, the topical antiviral therapy may actually be aggravating the problem of the patient. In patients with severe pre-existing ocular surface disease or toxicity issues, or where the topicals are not available, or in immunocompromised host. So the usual dose is acyclovir 400 milligrams 5 times a day, and valacyclovir 500 milligrams 3 times a day, or famciclovir 250 milligrams 2 times a day. Usually it is given for about 2 weeks. The adjuvant therapy would be debridement and cycloplasmic drops, topical antibiotics to prevent any superadded infections, and steroids are not required and not indicated at all in this scenario. And long-term prophylactic treatment is recommended if there are more than 2 recurrences per year. Something I want to talk about is a herpes simplex virus dendritic epitheliopathy. Now, if we look at this casually, it appears to be a dendritic ulcer. But again, there is a poor fluorescein take-up. There are no terminal bulbs, and there is no ulcerated epithelium. Stains poorly with lysamine green. Also, rose bengal staining is taken up poorly. So this is classically seen in a healing herpetic dendritic keratitis. And these are patients where ideally the topical antiviral treatment should be actually stopped. Patient should be put on lubricants, and usually this sheds off and the patient becomes okay. So, if you do not recognize this and keep continuing antivirals when this lesion is having a toxicity of the surface, you will simply prolong the duration of the disease. So this is something which, in addition, I wanted to talk about. And thank you very much. And any questions I would be happy to take. Thank you.
Dr. Amit, wonderful talk. I would just like to highlight one thing that you said. That is when you have a negative staining of the lesion, like very early stages, the epithelial cells are ballooned up, and you put a drop of fluorescein, it stains the base of those ballooned up cells. And you correctly said that now these cells will coalesce and then that forms the dendrite. I think that is the early stage where we should catch it when the patient is symptomatic rather than when it becomes a dendrite. And you have given a very beautiful presentation. And I remember Ritu Arora ma'am saying in a talk on how you should stop the antiviral on time and not prolong it when there is epithelial, when it has already healed. So all in all, a beautiful presentation. I would just like to ask the panel, do you prefer Verson gel or do you prefer acyclovir?
Ma'am, valcyclovir, I feel, ma'am, for the past 7-8 years I've been using and is very well tolerated and yet to see any surface-related side effects as we see with the acyclovir.
You mean the ganciclovir, you mean, right?
Yeah, ganciclovir, ma'am.
Okay.
Well, what
We
will
still
be
use
the cost
acyclovir.
difference?
Sir?
What will be the cost difference between acyclovir and ganciclovir ointment to the patient?
Sir, I think it would not be more than 400-500 rupees. I don't think it's that expensive. I don't think so.
But I just have to make one point that at the moment, there is only one brand of topical acyclovir available in the market. Cipla has stopped making topical acyclovir, and it's only FDC brand which is available. And again, I've got nothing to do with the brand, but I've seen in the earlier days, Zovirex used to come from Burroughs Wellcome. So when one would change the brand also, sometimes the response differs. So I am somehow going more towards oral acyclovir, except if it is the first episode. And Verson gel wrote 5 times a day, but I think you can give it 3 times a day.
3 times a day, yes, ma'am. 3 times a day works very well.
It's to be given 3 times a day, not 5 times a day.
I have a question for the panel. Does anybody take a sterile bud and debride that? I mean, does anybody do it? Oh, you do it?
Not nowadays.
I just take a sterile bud and just use this one, sir. Dipped it in the povidone iodine solution. Just touch the surface. No disturbing the surface. That's all.
I mean, don't you think it would kind of because it's an infective lesion full of viruses, it would kind of spread it around or something?
No, otherwise sometimes I just instill a drop of povidone iodine, sir, along with paracaine. So since it is topical anti-virucidal also, probably that would take care of the surface affected cells, like infected cells.
Correct.
We've heard Dr. Rao also mentioning this in our early fellowship days. Dr. G.N. Rao also used to say that just debride or touch it with povidone iodine. That's what he used to say in the beginning.
But those days didn't have a good acyclovir.
But at that time, oral acyclovir was not so much available, and even topical acyclovir was not available. I think in the current era, when we have easy accessibility of oral acyclovir, I wouldn't like to do it.
What percentage has the panel seen bilateral viral, not only epithelial, stromal, endothelial, and other things?
It's definitely there. I think it's around, it's more than 2 to 3%.
Yes.
We are a
It's more than what is given in the literature.
Yes, I would say definitely much more than
especially immune compromised diabetics as well.
The American Academy takes it up to 12.5% or so.
We have done a study of last 10 years of our viral. We found 7% almost to be bilateral.
If I may make a comment.
In post-COVID-19, So has anybody of the panel seen more increase in the bilateral disease?
I
Not
haven't seen any difference pre and post COVID. Dr. Basak was saying he sees a lot of viral post, but
Yeah.
the percentage I've seen is pretty much the same.
Because I also agree with Dr. Basak sir, ma'am. Post COVID-19, we are also seeing a lot of surge in the viral keratitis.
There is no such change in my practice.
Yeah.
Maybe
Even I have not seen any change.
I'm not saying it. Maybe in
Me
northern
too.
India we are not seeing
We
those
haven't
numbers.
seen surge in viral at least.
I think
Where
more,
we are.
more, diagnosis happens in the eastern part of India, Dr. Basak has extreme suffer cases. I remember his fungal keratitis rates. Once it was, more than 60%, 64% at his place. Then he had the highest percentage of Fuchs endothelial dystrophy in country. Now he says viral is the most common presentation. I think it would depend on the area, and I think people maybe they are having a much more physical strain.
Plus, if it's a referral practice,
That's true.
there
And
also it
he
will
gets a
make
lot of patients from a nearby country also.
all the eastern part of
Eastern.
country gets.
Okay, thank you.
Just to add one thing, that debridement would probably help in patients who are immune suppressed, like as sir said, that leukemia and all, to decrease the viral load in such patients. So maybe it can be considered in such patients.
And I
No,
think
I
one of the
wouldn't agree with
important
that.
differential.
Sorry, I probably would not agree with that because in viral keratitis, debridement or scraping is reserved only and only when you have multiple recurrences and your diagnosis is in doubt. In contrast to other disease, the high propensity, like somebody pointed out, that you can actually infect the deeper stroma. It's a very virulent, short-lived but virulent organism. So while povidone can be used as topical installation, may or may not work, but no harm done, I would be conservative about putting a scalpel or a blade on the surface if I know it is a dendrite.
Yeah, just one point. In case you're planning to send for cultures or anything or any tests, then do not stain with rose bengal. Stain it after, because it's itself virucidal. So then your yield will not come. So that's better to do if
That's a
you're
good point.
planning to send that. Yeah, right.
Okay, a bit. Very nice point.
Good point.
Thank you, sir.
Thank you, sir, for a very informative talk. And we move on to our next talk in the session, that is HSV stromal keratitis, taming the brood, by Professor Ritu Arora, ma'am. Over to you, ma'am.
Yeah. So thank you, Dr. Bhavna, for considering me for this particular session. And it's a very nice discussion we've been having. And after epithelial keratitis comes stromal keratitis, which is, of course, not so easy to manage. And I'll be just sharing some of my experience in managing these cases, these kind of viral keratitis cases. Just to begin with, Radhika has already shared about this, that broadly, if you see, it's very important in a suspected case of HSV keratitis to know that which layer of the cornea is primarily involved. At times, it may not be limited only to epithelium. It may be combined, and that's how, or only the endothelium, or it may be on the iris which may be involved. So the management is going to differ. Though Amit has very nicely dealt with the epithelial part of the disease. And when I come to talk about stromal keratitis is now divided into two main things. It is stromal keratitis without ulceration, or it is stromal with ulceration. And the terms which were given initially were stromal without ulceration was called as immune stromal, or non-necrotizing or interstitial, while with ulceration was called as a necrotizing keratitis. It's still, the terminology is like this, and this helps in the management of diseases. And I'm a big fan, as I said, of use of oral acyclovir, because I was at Wills when the HETS trial was being conducted in late 90s. And I saw that how the responses were coming, and our aim is that we should leave the patient with minimal corneal scar. So I am very liberal with the use of oral acyclovir, and the topical acyclovir also has its own side effects. That's just by the way. So In cases of stromal without ulceration, the primary management is because it's an immune-related thing. We give topical corticosteroids, which is the mainstay, plus prophylactic dose of antiviral, that is 400 milligram BD of acyclovir oral. In cases when we have stromal with ulceration or a necrotizing, we give antiviral, which is a treatment dose, which is oral antiviral. It is 400 milligram 5 times a day, or I may even go to 800 milligrams in rare cases, plus topical corticosteroids. And I'll just be running you through some of the cases. I've already talked about that stromal keratitis is primarily an immune response to the epithelial disease or to the HSV, which is invading the anterior stroma via the nerves or direct spread from the epithelial infection. So it may be non-necrotizing or a necrotizing inflammation. The different forms it comes with, it may come with intact epithelium, it may be focal, it may be diffuse, it may be multifocal, it may be associated with anterior uveitis. The beauty of viral keratitis is that sometimes it just comes with mixed form of all the layers being affected. And in, in necrotic form, it may be necrosis, ulceration, and dense infiltration of the stroma and associated with epithelial defect. HSV DNA has been isolated in these kind of cases. Therefore, there comes a role of giving oral antivirals. At times, the stromal keratitis may have a very severe inflammatory response, and I'll be showing you some pictures of that, which may lead to corneal thinning and perforation. The specific things which are with herpes stromal keratitis, that there is a higher risk of recurrence. It leads to corneal scarring and thereby diminishing the vision. So the endeavor always is that how we can get a minimum corneal scar to avoid any surgical procedure. It may lead to thinning. It may be associated with neovascularization. It may be associated with uveitis. And this stromal keratitis formed the basis for the HEADS trial, for the placebo-controlled double-masked multicentral HEADS RCTs, and it was labeled as HEADS stromal keratitis not on steroids and HEADS stromal keratitis on steroids. Because at that time, there was a debate whether steroids should be given in cases of herpetic stromal keratitis. There was a big difference in the East Coast and the West Coast corneal surgeons, each preferring having their own whether steroids should be given or not. And the response and the results was so phenomenal with steroids, they had to terminate the trial in between. And just primarily going over the treatment guidelines for HSV stromal keratitis, I've already talked about. With intact epithelium, you give oral antiviral agent combined with topical steroids, and steroids are tapered over a period more than 10 weeks. Sometimes you really don't know when to bring it down, because the moment you bring it down, faint stromal edema starts coming. Stromal keratitis with ulceration needs a therapeutic dose of antiviral in early stages and judicious use, because there's an ulceration we've always been talking about. As long as there is epidefect and fluorescein, do not give steroids. But in these cases, we do give judicious use of topical steroids. And when I put the patient like this on steroids, I follow up this patient every 48 hours just to see when the defect is healing. And these are the different criteria when I say the treatment is failing, whether there's a worsening of stromal inflammation, development of uveitis, no change in stromal inflammation. Now, this is my first patient. If you really see, this patient had come to us last year, presented by this kind of a dense corneal opacification. You can see eyes absolutely white, and she had this kind of a lesion 2 weeks prior to presenting to us. And here, when we made a slit, though I'm not showing the picture for that, it showed very dense stromal edema only. The patient was put on oral antiviral prophylactic dose with topical steroids. And within a week, you can see the resolution of the corneal edema. And this is the 1-year journey of this patient. You can see that this is at 4 months, when there are just 2 small infiltrates left, and there's another circle. And further following up with this, when there is a faint scar left, patient I have shown you these different, the broad slits help us very well in these kind of cases, because otherwise you may miss this disease. And when I make a broad slit under the indirect illumination, you can very easily see that there is present superficial level epithelial opacification. With prophylactic dose of antiviral and topical steroids, this is the final condition. Patient is having 6-9, and that's how you can improve. But what is most important, that patient needs to be under constant follow-up to get down to this disease, and has to be educated that this disease is recurrent, and it is very essential to keep showing the corneal surgeon. This is another patient who presented to me 4 weeks back. She was a known case of viral keratitis outside, and she had started with this kind of opacification, and she was unable to open her eye. You can see that there is a localized corneal edema. Before coming to me, she was, there was antiviral topical ACV being given. There was no response by the time the patient had come and said that she had worsened. So this was a typical, when I did a fluorescence stain, I could see an epi defect. And this is a slit which I have taken from different parts of the ulcer. What's important is to take the slit from the ulcer. You can see the central figure is showing an epi defect. Even the extreme right is showing an epi defect, but bottom left is showing very severe corneal edema. So it's very, very important to mark out the area which we are area of interest. This patient, I started the patient on systemic antiviral, and though there is a defect, I've started topical diluted steroids and a close follow-up. And you can see within 3 days, when she came, but the first time when she came, she couldn't open the eye because of stromal edema. She has started healing, and the cornea has become quieter, the defect has become smaller, and there is only one area where there is present defect, and the stromal edema has become less. So this is a typical case of a stromal keratitis with ulceration being managed with steroids and therapeutic dose of antiviral. This is further 3 days later. Eye is further become quieter, it started having a scar, and the epi defect has further become smaller. Topical steroids we have to use judiciously, because sometimes when there is a thinning, this may lead to perforation, and there is also a scope of secondary microbial keratitis happening. So a close follow-up in these cases is essential. This is another case which I wanted to show. This case came to me in November with a very vague history of a fingernail trauma, and said that after Diwali he had lost vision. And he had been treated with all kinds of things, but had not responded. He had finger counting 2 meters vision. And if I really see very closely, I could actually see that he was having very, very severe uveitis. They were very severe, dense KPs. And when I did the stain, I could see that inferiorly, it's a very non-specific, not that kind of a dendritic stain which Amit was trying to show, but a kind of a diffuse stain, no pattern being followed. And you can see the same picture when I took it without cobalt filter. And again, in this lower left, you can see that there is dense uveitis. I wasn't very sure whether I was dealing with herpetic keratitis. And before starting these patients on steroids, I always do scraping from them, because I've seen sometimes acanthamoeba may present like that, and that may make the things worse. We got the topical scraping done for that patient, and it just came out that no organism was seen. So I could start the patient on topical steroids, and you can see how the defect has started coming down. And this is over the period of like 1 month. The whole lesion has resolved, the uveitis has resolved, and patient doesn't have any defect. And in the lower right, you can see this picture. Where is this present? This kind of a stain, which is again because of the drugs which were being given. And this is what I agree with what Amit said, that some kind of a dendritiform things happen. So this patient, of course, I never gave topical acyclovir. It was only managed with systemic acyclovir, and he has regained his vision. This is another case I want to show. And since this is a long-term follow-up, I do not have the earlier picture of this patient, but he was a known case of viral keratitis who had had 4 episodes in the last 5 years. And every time he was left with a scar. And normally now the patients are so educated that the moment they realize something is wrong, they come to you very promptly. And they come with, oh, I'm having some kind of a photophobia, is aankh theek nahi lag rahi hai. That's how they come and tell us. So this is when I looked at it. I could get a stain which is very diffuse, no particular pattern. And if you see in the diffuse, you'll see intense vascularization. And there is present a central epi defect. I was managing this patient on topical ACV and systemic ACV, but no steroids had been added because this defect was there. And I thought, because let the defect heal. The defect never healed. I thought maybe he's getting some secondary infection. I got the scraping done. You can see the scraping report. It just went in favor of some viral cytopathic report. And in front of me, the cornea perforated. There is present a secondary infection. I was giving the patient everything, and I thought maybe it's a secondary viral keratitis. But I changed the patient to valacyclovir, and valacyclovir 500 milligram TDS, and no steroids because the cornea had perforated. He regained, and this is what the patient became, 4 years. This is 4 years after that. Then COVID came, he was lost to follow-up. And then I was very surprised. 4 years down the line, he has got this kind of a picture with a faint nebular macular corneal scar. It's unbelievable, but that's how they come. And here I have, again, in valacyclovir, I feel the brand of the valacyclovir which you're using makes a difference. I do not have any financial interest in that, but there are certain brands with which I'm happier than being used, the other brands. This is another case I'm currently dealing with, who has, if you see, this is the right eye, 4 o'clock area, healed case of a viral keratitis, had left a scar over here, was doing well for 6 months, till he came to me about a month back with, some congestion, and you can see some defect over here. And this defect over here and this area of the cornea is, you have to be very particular where you take a slit. So there is present a localized area of a corneal edema, which is going in favor of stromal keratitis with ulceration. I was again hesitant to start the patient on steroids because of the defect and the thinning. You can see the defect is persisting, and this is only with oral acyclovir. The defect has increased. It looks like a punched out lesion. I was confused. Am I dealing with some kind of a trophic element in this case? Sometimes trophic element also adds to a confusion. Well, this ulcer never healed. And then I started the patient. You can see, because this is the patient seen every 3 days. You can see this punched out kind of a lesion, and there is present this defect, and there is present stromal edema. It's only that when I started the patient now on topical steroids, you can see the defect has started healing, and the defect is much smaller, and even the patient is better with oral acyclovir. So what I'm trying to say is the judicious use of steroids, whether you are going to use diluted steroids, though the AAO recommendations and head's recommendation is to start prednisolone, whether you use it BD or TDS. But because of the thinning and our kind of setup, I am little hesitant to put them on pred, but I start them on loteprednisolone and see the patient every 48 hours. This is another patient about which I was talking about, who had come to us at first visit, left eye, who had simple corneal opacity, had undergone and had an optical, some kind of an iridectomy done inferiorly. Right eye at that time was clear, and he underwent a keratoplasty. You can see it's fine, and then there is present, some iridoplasty was also done. 6 months down the line, he presented in the right eye with this kind of a lesion. There is, if I stick the slit, there is a stromal edema, and there are present KPs at the back. And then it's when the thing became clear that he is actually, I am dealing with a deep stromal keratitis. We managed the patient. You can see I started the patient on oral acyclovir and topical steroids, and could get the patient to a small scar afterwards. This is another variety of a necrotizing keratitis where at times patient may come and you may feel as if it's like a corneal abscess. There is a severe inflammation in the cornea and there is present vascularization at the base and there is this kind of an infiltration happening. I mean, I started seeing these cases maybe 20 years back. At that time, I did not know what I was dealing with, but since at Wills, I had seen a lot of these cases. So I was clear that later that this is a necrotizing keratitis we are dealing with. And they used to feel that in India, we don't get so much. And then I shared it with Umang and he said he had also seen a lot of those kind of cases. So you can see there is a stain is positive. It looks like as if there's a corneal abscess. I have started the patient on 400 milligram 5 times a day oral acyclovir and diluted steroids. You can see the eye has become whiter. The scar remains, but here it's very important to differentiate whether we are dealing with a scar or we are dealing with edema, because disease is recurrent in nature and it depends from where we are taking the slit. So this is a dense stromal infiltrate and ulceration, and patient has resolved, vascularization has reduced, the infiltration has gone, which you are seeing. And these are the patient. I may like to take the patient on PK if the other he's only one-eyed. This is another case of a recurrent stromal keratitis. At times, they may come with this kind of an opacification or edema in one area, and then they come with another area affected. This is my one-eyed patient who keeps getting recurrent multifocal, I started in the beginning, stromal keratitis. So every time I take a slit, I draw a diagram, I know which is the area of concern. And this is the only eye for the patient. He has 4/60 vision and he says he's fine. The moment edema increases a little bit, he comes to me before, somebody else can pick up. Patient picks it up much before. So the less common presentations which I've seen lately of stromal keratitis is deep stromal vascularization and a Descemet's duplication. This is another patient who came to me 2 weeks back. If you really look at it, there is not much of a scarring. Very faint scar you can see. Patient had a vision of 6/18. And if you see on retroillumination, there is dense corneal vascularization happening at the deep. You can see this kind of a corneal vascularization at the deep stroma level. If you make a slit, as I was telling you, you have deep stromal area. There is present this scarring and vascularization. And when I got this is the ASOCT, which Radhika was talking about, and I agree with her, that which sometimes helps you to plan. I could get this scar right down at the Descemet's level. And in case, of course, I'm not planning for PK, but if this kind of a patient one has to do, it will be only full thickness corneal graft. But she has 6/18 vision, so she's nowhere near that. And this is I am monitoring this patient with anterior segment OCTA, and just to see if the vascularization is going down. Patient has been put on prophylactic dose of oral acivir and topical steroids. This is another patient who came to us about 10 months back with localized inferior corneal edema. Vision was only 6/9, and but the edema you can see is coming to mid-pupillary area. It looks like as if there is present some kind of Descemet's tear. But if you really see on the slit inferiorly, I've never seen this kind of thing before. There's some kind of a projection happening in the anterior chamber. And it's only later when I did the literature review that I found some odd cases of Descemet's reduplication, which also happens in viral keratitis. So we managed this patient initially only symptomatically with BCL and all. And though patient was 6/9, but not a very clear 6/9. Then I added the patient on prophylactic dose of acivir and topical steroids. And you can see the lower picture, how the cornea is cleared and inferiorly there is only present some kind of edema. You see the slit, the duplication has stayed like that. ASOCT is showing you this is the area of Descemet's duplication and edema has gone down. This is another patient which was referred to me who had a multifocal IOL, had regained vision, and then 2 months down the line had a loss of vision. You can see central area, there is present a deep stromal edema and is a localized stromal keratitis, which could be mistaken as a PBK, which Amit was talking about. But this was clear-cut case of viral keratitis, managed with steroids, but edema never resolved completely. And of course, she's no more now. The common presentation of viral keratitis is the combined presentation of epithelial and stromal keratitis. So it's very important to evaluate each element and go for the therapeutic mode accordingly. Misdiagnosis, where when it is not viral keratitis but diagnosed as viral keratitis. This was one of my cases who was actually a case of PUK, marginal keratitis. I did phaco for this patient 8 months back, and he was doing well with 612 vision till he came with this kind of a peripheral at 9 o'clock. You can see a peripheral defect. And there was present some kind of, you can see on fluorescein, some kind of a central epidefect and this fluorescein over here. He had been put on topical antiviral, but he never improved. I knew that this was not a case of viral keratitis, but a marginal keratitis. Just adding steroids and withdrawing ACV helped the patient to heal and complete resolution of defect. It's not uncommon when there is a viral keratitis and it is missed, and when there is no viral keratitis but diagnosed as a viral keratitis, and patient is putting topical ACV and gets a lot of side effects due to ACV. This is another patient which was shown to me in end of April, that for 3 months they had been treating this patient as a viral keratitis. And I said, okay, 3 months you've been treating, look like stromal edema, and patient was on valacyclovir 500 mg OD, and I continued with steroids. But within 3 days of when I saw the patient came with this kind of an infiltration over here. And on detailed history, she admitted overuse of contact lens. And this was actually a case of acanthamoeba. So then I withdrew everything and managed the patient with anti-acanthamoeba drugs, and she has completely healed. And this is another case where there is a long-term recurrent keratitis, maybe dendrite. So, and they were using the word of metahepatic keratitis, but it's there in the old books. No longer we use the terminology. It's a trophic epithelial keratitis where there's a damaged basement membrane, and that may give you a doubt, what am I dealing with? Sometimes there's a thinning associated with that, and sometimes there is a trophic ulcer, and the management has already been discussed. Rarely, when you do a cataract, and if you do not happen to put the patient on prophylactic antiviral, they may land up with, this is a patient, one of my patient only, this was the only eye. I did a simple ECC in this patient because he had a corneal scar, and somehow the antiviral was missed, but because they are put on steroids after that, she landed up with microbial keratitis. So in the end, I just want to say that as per my understanding and AO guideline, the stromal involvement by HSV can be differentiated from epithelial and endothelial by simple slit lamp biomicroscopy and use of fluorescein and rose Bengal. And this helps the practitioner to balance antiviral and topical corticosteroid therapy. Valacyclovir is as effective as acyclovir in preventing the ocular HSV recurrences. And long-term, sometimes when I put my patients on long-term ACV, 400 mg BD, they always ask when it's going to be stopped. My answer is always, I do not know. And that's what the earlier trials have also said. And patients who have, it's very specific, with a history of HSV keratitis should be educated about their relative risk of recurrence, acquainted with signs and symptoms with recurrence, and they should come to ophthalmologist as early as possible so that they have a minimal scar. And these are the AO guideline where they endorse the use of systemic ACV. And this is in summary, which I've already talked about. Thank you for your kind attention.
Thank you, ma'am, for a very detailed description of diagnosis and management of options of stromal keratitis. And it was very indeed, informative for to learn about the delicate balance between the antiviral agent and topical steroids in managing the recurrences and adequately treating the patient as well. Thank you, ma'am.
I just want to add one point. Ma'am was saying acanthamoeba being mistaken. We had a patient with microsporidial stromal keratitis, which we kept treating with steroids. And he went to Chennai, and I think Meena Lakshmipati pointed out it was microsporidial stromal keratitis. At that time, we hadn't seen many of those, but scraping, as ma'am said, is very important to distinguish.
Before I start the patient of epidefect on steroids, I like to do scraping.
This
Also
patient had
one
no epi
role,
defect, but deep stromal infiltrates. And we kept thinking it was stromal keratitis, whereas it was microsporidia.
I just have a question for ma'am and the panelists, if I may. Yeah, ma'am. Yeah, what is the role of oral steroids? Because I find that in stromal keratitis with an epithelial defect, under adequate cover of oral antivirals, a therapeutic dose, when we are hesitant to give topical steroids, a short dose of oral steroids, I find takes the care of the inflammation very well. And
I
then
have
as
never
the
given.
effects. So
I have never used oral steroids in these patients.
any
Never
of the other panelists, because
no, I don't know what about others.
We don't use oral
we
steroids,
don't.
only topical steroids.
Topical steroids and a close follow.
One
And
question.
in case of doubt, before starting steroid, as ma'am rightly said, we should do corneal scraping
I think
also.
that is mandatory for any patient to be doing.
Not every patient, but in case of
Yeah,
doubt.
yes.
I have a question for Dr. Ritu ma'am. I
Yeah.
think I agree with all your points, and it's fantastic to listen to your comprehensive compilation. And viral keratitis is one disease which can probably mimic various other presentations, and unless you are really vigilant and you're able to differentiate, we could very well land up misdiagnosing and treating them as for something else here. The particular difficulty, as you rightly pointed out, is those cases which present with a posterior stromal and endothelial manifestations. And these are particularly more difficult to treat, more difficult to diagnose. And these are cases which I find, even if you do take them for an endothelial transplant, and many of these patients are adamant and want us to do an intervention. And I do find that their grafts do not do so well. And despite the most vigorous, despite, a preoperative antiviral therapy started about 4 to 6 weeks beforehand and taking it on. So that's one particular group of patients I find it's very difficult to treat. And there is the second group of patients who have a multi-layered disease. They have epithelial, stromal, endothelial disease, and they invariably have asymmetric presentations in both eyes. And we have to take them in for keratoplasty, much against what we want to do because of their poor vision in both eyes. And these are patients, even in long term, they just keep coming back to us, whatever we do, despite the antiviral. That's the second stream of patients, which I find is very difficult to manage. And the third one, which I do see, is when they present like an interstitial keratitis kind of a picture. There is a sclerocorneal involvement. You do not have a clear area between in that circumferential region which is involved, and it goes on to involve sort of a particular half of the cornea, and then both corneas involved, they are asymmetrical. And this is something I specifically find very difficult. I have two such patients who are following up with me. One came with a vision about 6/18, gradually has gone down in one eye, and the corneal involvement in the posterior stroma and the mid stroma has progressively increased and is now sitting for an endothelial transplant. We did an aqueous tap, did not get anything on the aqueous tap for that patient, but a serum showed a positivity for hepatitis B virus in that patient. He's waiting for an endothelial transplant, and I'm keeping my fingers crossed, trying to push him back as much as forward, because the other eye is still having some amount of good vision. So your thoughts on how to deal with these kind of cases, ma'am?
I am as clueless as what you're talking about.
Yes, and these are real dire ones, and I have two of them sitting with
me.
me.
Very challenging.
Yeah, yes, okay.
I agree.
Yes.
We see
Thank you so much.
patients who are on oral acyclovir twice daily, meticulously taking drugs, and they come with recurrence.
I agree with you. Yes.
Here I do not know. They used to earlier say that there is no resistance to ACV. Earlier they used to say. So now my thought is whether they are getting resistant to ACV, and then nothing against Indian ACV. I now have started having my own doubts against the bioavailability of acyclovir from
which is the preferred one, ma'am, which you prefer to use? You will not.
It's very difficult to say,
Okay.
but same thing. I've had these. I don't know. I wanted to discuss. I didn't want to discuss it, but now it's come up with that. I don't know. I want to hear from others. Earlier, till like 2 years back, none of my patients with oral acyclovir ever had any recurrence, as long as they were taking it. It's only they would stop it. It's nephrotoxic, and therefore one had to be cautious about that. And then some of my patients, I have put on valcyclovir, and I found that patient which I showed who improved significantly, I had given him Valtrex.
Okay.
Valtrex is a valacyclovir brand coming from GSK.
Okay.
And while I have seen valacyclovir, which is coming, drug companies are going to sue me. So, which from others, I want to ask others if they've had this kind of an experience.
Yeah.
And same thing, it happened with me long time back when Zovirex was given, So because Zovirex used to come from Burroughs Wellcome. Zovirex, they've stopped bringing it out in the Indian market, So I have started having my own doubts whether the bioavailability of antiviral in this medication is to the mark or not, because systemic level of acyclovir to reach that therapeutic dose is difficult. It only stays only for 4 hours. T-half is only 4 hours. That's why you need to give it for longer period. So I would like to be very sure of whether the brand which I'm giving is, and I tell patients who can afford, I said, please, if you can get it bahar se, please le lo. Again, not to be quoted. But I've seen them doing it.
Yeah.
Yes, thank you.
Experience of others.
Yes.
I have one query. Can I ask?
Yes, please.
Go ahead, Raki.
I think we're time.
Thank you, ma'am, for sharing very challenging cases of stromal viral keratitis. There is one situation which is really challenging to us and most troublesome. That being in an institutional practice, we get most of the patients with non-healing keratitis who come to us. They have already been taking a lot of medication of all antimicrobial, like antifungal, topical antivirals, antibacterial. So in these cases, when they present to us, what pointers would you suggest to look for, whether it is for establishing the diagnosis of herpes stromal keratitis or to rule out HSK?
It's a very important question. It's short of time, therefore I'm saying, I'm just putting you stop here. Very important. This thing was very often patients are getting a cocktail of medication. They're getting antifungal, antibacterial and everything, they're getting. So I always like to do a good scraping and have a very good ocular microbiologist who can pick it up. And only when on microbiology, like she said, they picked up microsporidosis or we picked up acanthamoeba or other things, So, of course, I've sent 1 or 2 patients even to LVP Hyderabad for the management, and things change, but it's difficult. Maybe we're short of time, so we can go and then do it. Scraping will give the answer, and maybe Anubha can answer that question.
Thank you.
Also, just GIMSA is a good point when you are already scraping. GIMSA
Yes.
gives good sort of head start if you have these viral cytopathic changes. And that's something I really use a lot in my clinical practice.
Yes.
So we invite our next speaker, Dr. Anubha Rathi. She'll be speaking on endothelitis and keratouveitis, all that you need to know. Over to you, Anubha.
Is my screen visible, Am I audible?
Yes, go ahead.
Yeah. Hi, good evening, everyone. I am, first of all, thank you to AIOS and Professor Bhavna Sharma, ma'am, particularly for including me in this elite group of presenters today. I would be speaking about viral endothelitis, keratouveitis, and all that you need to know. I just want to know if my slideshow is also visible. You can see the slideshow mode. Yeah. So I'll just tell you the overview of what we will have today. We'll be dealing initially with HSV endothelitis, then a very brief overview of of CMV endothelitis, and then keratouveitis, particularly herpes, and some challenging situations. There's one particular one which we faced where there was some double trouble. So why and how does HSV endothelitis occur? So as there have been several talks before me just now where we have realized that, stromal component and endothelial component, there is a very important immunological etiology behind endothelitis as well as stromal keratitis. So here also immunological component is very important, which is what governs the treatment as well. That is why steroids play a very important role in management of endothelial herpetic or any viral endothelial involvement. So how it occurs? Well, what we have been knowing from time and again is that it is in three forms. It can be disciform, diffuse, and linear. But herpes doesn't listen to this most often. So it is unlikely that you will find typical cases of herpetic endothelitis, which cater only to one particular type. What I can tell from, from this particular slide, a takeaway message would be that we need to look for corneal edema. If it is present without any, overlying corneal infiltrate, and there is an underlying keratic there is a presence of underlying keratic precipitates with or without iritis. And what is important to understand is that the edema will be in the KPs will be in the area of the edema. So the rest of the cornea beyond the area of KPs would be clear and uninvolved. We are talking of purely endothelitis here. So again, just to cover before we move on to some interesting cases would be the three types which we have known for a very long time. So disciform, as seen over here, would be something which will be localized. It will be a round area. Usually it is central. And you will have stromal edema, you can have limbal injection, multiple KPs, everything lying within the area of the edema. We need to obviously differentiate it from what we have discussed already, the immune stromal keratitis. You can see the presence of KPs and the deeper involvement and actually differentiate it. Clinical diagnosis is the sine qua non that has to be done before any microbiology. I think clinically the slit lamp examination still is the gold standard. So coming to the diffuse endothelitis, there would be a diffuse corneal edema with scattered KPs all over, and rarely you can see some retrocorneal plaques of inflammatory cells. Even a hypopyon can be seen, which could be reactionary as well as infective in cases of HSV, deeper involvement like endothelitis or keratouveitis. Linear endothelitis is something which is very difficult to treat at times and sometimes even misdiagnosed, especially if it happens after a corneal graft. It is sometimes difficult to understand whether you're facing a rejection or a linear endothelitis or a HSV recurrence. So it would be important to see if the origin of this particular condition is usually from the limbus and then it moves towards the center. So unlike what you would see in a graft recurrence or in a graft rejection. So here the graft host junction would be crossed when it is a HSV recurrence. So we'll move to some interesting cases. This is the first case I would like to discuss today, and this is about a 45-year-old lady. And we have again heard this many times today that a lot of endothelitis in particular is misdiagnosed as phakic corneal edemas, as well as keratopathy, and they get referred for endothelial keratoplasty. Only when you actually go in a little deeper, you realize that what you're dealing with is actually herpes or any virus for that matter. Here, mostly when I say virus, I would be talking about herpes. So in this particular condition, if we see there is a differential corneal edema, you can see that the upper part of the cornea is not that edematous, whereas the inferior and the central part is more edematous. There are some keratic precipitates which are lying within. It might not be that clear in this image, but there are some KPs, fine KPs, which are present. There is a pupillary rough atrophy, which could indicate previous attacks of uveitis. And the clinical diagnosis, as I said, is the usual way we go forward. Microbiological diagnosis or AC tap or an aqueous tap and PCR can be done if you are in doubt, but most often the diagnosis would be clinical. So in this patient, we made a clinical diagnosis of HSV endothelitis. We started this patient on topical steroid prednisolone acetate 6 times a day, which would be slowly tapered. Slow tapering is the rule in endothelitis. The oral antivirals, acyclovir is the drug of choice which we have used here. 400 milligram 5 times a day for the first 2 weeks, followed by prophylactic dosage. Then this patient later, based on the the endothelial recovery, can undergo either an endothelial keratoplasty with a cataract surgery or a cataract surgery alone based on the recovery. So coming to the second case, this is a patient whose complaints were only for 1 week, but gave a past history of undergoing trabeculectomy for persistently high IOP and recurrent episodes of pain and redness, and has received oral as well as topical antivirals infrequently before with no proper prophylaxis. So here also very similar picture of localized corneal edema was seen with a flat bleb and a large PI post-trabeculectomy. This patient has history of IOP spikes, has a history of glaucoma filtration surgery, and on digging, we could even see that some PG analogs could or may have been given. So these are few pointers which actually go towards the favor of HSV. So here again, this is a mimic because, glaucoma attacks, IOP fluctuations also can lead to endothelial decompensation. Even because this patient has undergone a cataract surgery, even complex or complicated cataract surgeries can cause. So I think it is important to look for specific pointers of HSV when we are, before labeling this as a simple case of pseudophakic corneal edema. So here again, we treated the patient with topical steroids and oral Acivir, have continued this patient on oral Acivir prophylaxis, and this patient underwent a successful endothelial keratoplasty later. The iris atrophy here is also something to watch out for. So in cases of recurrent herpetic attacks, particularly keratouveitis, we will find patchy iris atrophy or sectoral iris atrophy. Usually in herpes, it is sectoral, which is seen. And I'll come to that also in subsequent slides. Before that, I would like to take you to the third case. Here, this is a case of a 48-year-old lady who came with a 3-month history and again recurrent episodes. Again, the same thing, was misdiagnosed as some endothelial dystrophy-related bullous keratopathy and was referred actually for a keratoplasty, and was on hyperosmotics for 3 months with use of on and off topical steroids. So this patient, again, very similar picture. This patient also had ciliary congestion and KPs along with an AC cell, along with AC cells. So a diagnosis of keratouveitis was made along with endothelitis. This patient underwent the aqueous TAP and PCR was positive for HSV1 DNA by conventional PCR, and a similar line of treatment was started. So here, what is important to understand is whenever such a patient comes where a dystrophy has been suspected, it would be a good idea to see the other eye and examine the other eye, because dystrophy most often than not is bilateral. And if you're suspecting Fuchs or any other endothelial dystrophy, you would be able to find those signs in the other eye. So this particular patient, then this is how this patient is doing now and is planned for EK triple under Acivir cover. Again, the time of quiescence could vary from practitioners to practitioners, but this is what I normally follow, at least a 3 to 6 months of quiescence before going in for a keratoplasty. So this is something that, again, the same thing that, this is what I was talking about when I was talking about linear arrangement of keratic precipitates. So there are DM folds, there is an edema which is differential, and there is a linear arrangement of keratic precipitates. This is very lightly, if you see here, there is an immune ring sort of an appearance as well, which is actually disciform keratitis going into a linear, disciform endothelitis going into a linear one. So there is no clear area of demarcation between all the types which we have learned from ages. There is a lot of gray zone in between. So what we see are combined pictures. This is how this patient did with acyclovir and steroids. And in fact, I saw her this very day today, and she was doing very, very well. So this is another patient where the involvement is much more extensive. So we don't expect clearance of vision with just our treatment. So we have to look for some visual rehabilitative methods as well. So once the diffuse endothelitis resolves, this is how it looks. Though it looked so bad in the first picture, just simply with Acivir and steroids, this patient is doing so well. So initially, the thought may come, this patient has come in for a phakic bullous keratopathy and an EK should be done as early as possible. But if you just rule out herpes in such cases, you can save the eyes actually plan the surgery at a later stage when it is actually needed and under an antiviral cover. So this is another interesting case which was published by us in BMJ long back in 2021, but because it is something to do with CMV, I thought I would highlight it today. So not all endothelitis is HSV related. It is important to also rule out other viruses like cytomegalovirus. This particular patient had been misdiagnosed and actually was HLA-B27 positive, but had been thought of having HLA-B27 positive anterior uveitis and was on methotrexate and topical steroids for recurrent disease for a long time, and was also on maximum medical therapy for glaucoma. With high IOP despite MMT, despite the maximum medical therapy, the patient still had high IOP. So then that is when it was thought that let's do an AC tap and rule out viral etiology. So this patient had the localized inferior corneal edema, had medium-sized pigmented keratic precipitates. Also, these coin-shaped KPs were present on the endothelium. And to our surprise, on the AC tap, we found cytomegalovirus positive on PCR. This patient has responded well to oral valganciclovir, 900 milligram per given TID for the first 6 weeks, and then once a day for the next 6 weeks. And now the IOP is also well under control and the corneal edema also resolved. So it is important to understand that you have to differentiate between the various viruses also. Not everything is HSV. That could be the reason why acyclovir was not working, because valganciclovir is the treatment of choice in CMV. Also, the use of immune modulators like methotrexate for a long time can lead to a relative immune compromise sometimes in these patients, and CMV, which is otherwise mostly seen in immune compromised conditions only. So we must also rule out other underlying systemic conditions like HIV. So just a very brief thing that, KPs would be when you are wanting to differentiate between CMV, keratouveitis, or CMV endothelitis versus HSV, it is important to look for the AC reaction, which is moderately more in HSV as compared to CMV. But the type of KPs are usually the clinchers. The coin-shaped KPs in CMV is important. And also the iris atrophy is mostly patchy in case of CMV. And in 100% of cases, you will find IOP spike or IOP rise. So in keratouveitis, because that was the second part of my talk, but I feel that there is a lot of overlap in endothelitis and keratouveitis. I might have covered a lot of it already. I just want to say that iritis and trabeculitis can happen together. So IOP has to be checked in these patients, and that can be an important marker of viral keratouveitis. This is a patient wherein a 45-year-old lady came to us with 3-week history of photophobia and blurring of vision. This is something similar to what a few speakers before me have already alluded to, that if there is an epithelial defect along with, so not everything would follow the picture, the textbook picture, you will get complex cases. And in such cases, you can do a corneal scraping. That is what we did. And we made sure that we ruled out any polymicrobial infiltration. We only found IFA-PCR positive for HSV. Here we, similar to what Dr. Ritu ma'am was saying, we also started topical steroids along with oral antivirals, and this patient did very well in the post-op period and resolved completely by the end of 3 weeks, almost completely, and we continued the patient on a slow taper of topical steroids along with a prophylactic dose of acyclovir. So this particular patient, this is the patient where I was talking about the double trouble. So not every time you will get away with just HSV. Imagine if you have fungus along with that and you cannot even give steroids. So this is a patient where the smear on the first day, because there was a super added, we were thinking it's a polymicrobial keratitis that we are dealing with. So we did a scraping, and fungal high fever positive, and culture showed fusarium. IFA-PCR also showed positivity for HSV. This was a bit difficult to treat. The patient did well on simply oral antivirals, oral ketoconazole, natamycin, and atropine, along with we avoided steroids. And this is the last picture that I have of the patient, but we have seen the patient on follow-up, and patient has done very well. the infiltrate has scarred, but it was this hypopyon kept persisting till a very long time, which I think was reactionary. The congestion also persisted. We realized it was also toxicity of the drug natamycin. Finally modified that and were able to manage this patient, but we could not start steroids in the entire course. Before I close, I just want to say that there are, as we have also said, there are several mimickers when it comes to HSV, and in particular endothelitis. It is important to understand you must rule out Fuchs heterochromic iridocyclitis, Posner-Schlossman syndrome, and ICE syndrome. In fact, very interestingly, PSS and ICE also in their etiology theoretically have been linked to HSV. So it would be very important to rule these out. And before closing, just this last slide for takeaway. So independently, HSV endothelitis has been seen to occur, and it usually is treated, the mainstay is topical steroids along with oral antivirals. Even topical antivirals can be used, but rather than trifluridine or ganciclovir, endothelitis is usually managed only with acyclovir. I'm talking of topical. If epithelial or stromal component coexists, we must think about ruling out polymicrobial keratitis, and corneal scraping would be required in that case. IOP estimation is extremely important. Clinical diagnosis usually works well. You don't need microbiology unless and until you have doubt. Oral acyclovir prophylaxis is required. There are some reports to suggest that in endothelitis, the duration of prophylaxis could be shorter as compared to stromal. Visual rehabilitation options with DMEC and DSEC, we are usually able to visually rehabilitate these patients well, unless there is a mixed component and it is not purely endothelial or keratouveitis that you're dealing with. Recurrence in pure endothelial cases is usually lesser than stromal HSV. So thank you.
Yes, thank you, Anubhav, for a very informative talk on all the aspects of viral keratitis, not only HSV, but CMV and other pathogens. And it was truly a very informative talk. I think we can take the questions towards the end of the all the talks.
Thank you, Professor Bhavna. I think I would introduce you because you are next. So I would like to invite Professor Bhavna Sharma for the next talk on clinical spectrum and management of herpes zoster ophthalmicus.
Yes, thank you. I'll just share my screen. In the meantime, if there are any questions, it can be discussed. I'll take some moment to share my screen.
Aruba, one point, when there is very dense edema, then there is a role of ASOCT to just see the keratic precipitates. I suppose that would be one thing. The other thing is we share our cases of keratouveitis with our retina guys, and they treat the glaucoma people treat the trabeculitis, the Posner-Schlossman, and then you have this fine distinguishing line between when you have endothelitis purely or you have keratouveitis along with endothelitis, and it goes into the realm of the uvea specialist. So I would just like to ask the panelists how you would treat these conditions, pure endothelitis versus keratouveitis, plus minus a trabeculitis, which is thrown into the mix.
Treat it yourself.
Yeah, that is our retina guys or the /uvea guys, they want, we also give antiviral for a very long period of time. They throw in some oral steroids also, and they have their own take on the treatment. They do not agree really with the anterior segment people. So that's how it is in a tertiary care, I suppose.
Anubha, in cases of CMV endothelitis, any experience with topical ganciclovir?
So in endothelitis overall, there are studies to suggest that ganciclovir does not penetrate that well as compared to topical acyclovir. Trifluridine and ganciclovir has poor penetration topically. So oral is required for, and that too, there are studies to suggest Val ganciclovir usually works best in CMV, Dr. Pratik.
Okay. Valgan is damn expensive. Sorry for the term. It's very expensive. Sorry. Yeah.
So that's why I was asking for cheaper alternative.
Yes, maybe.
I think Dr. Bhavna, you're muted. We can't hear you.
Yes.
We can see. Yeah, we can hear you now.
Is my screen visible?
It is.
Yeah, it is.
Yes.
Yes. So thank you. Towards the end of this session, I would be speaking on clinical spectrum and management of herpes zoster ophthalmicus. And this is very important in today's scenario because we are seeing more and more cases of herpes zoster ophthalmicus in our clinical practice. And also that more and more young people are being affected. So herpes zoster ophthalmicus, the hallmark of the disease remains the painful vesicular rash over the fifth nerve distribution. And in addition to that, we have ocular involvement, which is present in more than 60% of the cases. Talking about ocular manifestations, as my previous speakers have already taken, it can range from conjunctival inflammation to corneal inflammation in the form of microdendrites, pseudodendrites, stromal, disciform, and nummular keratitis, and more deep-seated inflammations like keratouveitis, secondary glaucoma, and posterior segment involvement. Chronic eye disease is one of the important parts of herpes zoster ophthalmicus. As much as recurrence is for HSV, chronicity is for HZO. So we see many patients who land up into chronic eye disease, and I will be discussing them shortly. So when talking about the rash, given that the rash is the integral or the characteristic part of HZO, we must also be reminded of this entity, which is herpes zoster, without rash, known as herpes zoster, sign herpes. In this, the patient may present to you with minimal, there's some disturbance in between. You need to mute. So in patients of sign herpes, we will have a mild rash or no rash at all. However, the pain in the dermatomal distribution would be very characteristic or would be present. In addition, there would be presence of anterior uveitis, secondary glaucoma, and SPK in majority of the patients. So these are two patients which presented to us, this 32-year-old female who presented with minimal rash over this forehead, slight erythema, and pain, however, was significant in this patient. What clinched the diagnosis was the presence of a vesicle on the center on the tip of the nose, and she also had epithelial keratitis. This 25-year-old male did not present with any rash at all. However, the pain was present in the dermatomal distribution, which was severe in character, and in addition, he was having anterior uveitis. Both patients were diagnosed to be HZO and were started on systemic antiviral as per the usual HZO schedule. It is important that though the patient may not present with the typical rash, but we must give them the usual full course of antiviral medication, either acyclovir or valcyclovir in full doses. It has long been regarded as a disease of decreased immunity. However, it has now been seen that there are various reports that there has been increasing incidence and also that it is affecting more and more healthy individuals. And so this misconception that healthy individuals are not at risk of the disease or the disabling sequelae, whereas we are. So these are a few cases which came to us, absolutely healthy young adults who presented with HZO, like this patient who was 40 years old with eruptions and visual symptoms of 4 to 5 days duration. In addition, he had epithelial keratitis, which was treated with the course of oral acyclovir, in addition to analgesics, and topically we gave him ganciclovir lubricants, cycloplegics, and supportive. This 52-year-old male, he was also absolutely healthy. He presented to us with non-resolving pain and visual symptoms of about 9 to 10 days duration. He did show pigmentation and depressed scars over the forehead and was found to have keratouveitis and raised IOP. Both patients were adequately treated with oral antivirals and adjuvant medications, and they healed. Interestingly, in our series of about 68 patients, only one patient showed to have immunosuppressive illness. That was this patient, who was a 16-year-old male PLHA patient, was presented to us with vesicular rash and severe pain over the dermatomal distribution. Ocular examination revealed stromal keratitis and raised IOP. He also had posterior segment manifestations in the form of ARN and optic nerve inflammation, which can be seen here, and consequent vitritis with thickening of the retina choroid complex. This patient was treated with IV acyclovir. Such patients generally do not benefit much with oral acyclovir. So he was started on IV acyclovir in the dose of 10 milligram per kg, 8 hourly for 2 weeks in coordination with the neurophysician. And later on, after 2 weeks, he was shifted to oral acyclovir, and oral steroids were started for the posterior segment complication. He was also started on doxycycline and vitamin C and topical medications. The patient showed healing within 2 weeks of starting the treatment. So the treatment recommendations are that we should start oral antiviral within 72 hours of rash to all patients, because it reduces the incidence of chronicity and also treats the patient adequately. In immune-compromised patients, the dose of acyclovir is 10 milligram per kg body weight intravenously over 8 hours. In acyclovir-resistant cases, we have to give foscarnet in 90 milligram per kg dosing. Also, that HSO has been regarded as disease of elderly, which is also now a misconception, because we are now increasingly seeing patients of young age, and the mean age of onset has decreased to 52 years. The Merck study says that number of cases were highest in 50s. So again, a misconception here. It can be seen that these two pediatric patients of 12 and 16 years of age, absolutely healthy, who presented to us with severe vesicular eruption and ocular manifestation. Again, a series of patients, all young adults with slight male preponderance and all healthy without any immunosenescence. And in our series of 68 patients, again, the majority of patients, that is more than 60%, were of the age group less than 50 years. So the stressing here that the herpes zoster ophthalmicus is affecting more and more young adults, and also the increasing incidence is there. So it is important that we timely diagnose and start the antivirals as early as possible. Some complications of herpes zoster ophthalmicus, like herpetic neuralgia, ophthalmoplegia, posterior segment complications, other nerve palsies, and secondary glaucoma can occur because of various reasons, the major ones being the suboptimal treatment with antiviral agents, and sometimes systemic steroids are prescribed in the early phase of the disease. In patients who are immunosuppressed and systemic diseases, and patients over 65 years of age, there are increased chances of complications in them. I would be presenting a series of patients who presented to us with complications which were managed on time, however, but this case, a 48-year-old healthy male who presented to us with vesicular rash and skin excoriation of around 1 to 2 weeks duration, and also he had loss of vision in one eye because of secondary infectious keratitis with corneal melt. He had total ophthalmoplegia with restriction of all ocular movements and complete ptosis. Posterior segment evaluation again revealed on B-scan that he had ARN and vitritis. On further evaluating and taking history from the patient, it was informed that he had taken treatment elsewhere with antiviral and acyclovir in dose of BD 800 milligram, and also systemic steroids was prescribed as per his documents. We started the patient on acyclovir 10 milligram IV dosing in 8-hourly schedule, and later on he was shifted to oral acyclovir after 2 weeks. He was given intravenous methyl prednisolone in 3 pulse doses after we saw that the retinal degeneration was regressing, and after 2 weeks. We also was given tablet doxycycline and ciprofloxacin as per the culture sensitivity reports, and in addition, topical antibiotics and antiviral were given. This patient responded to treatment, and he showed resolution of ophthalmoplegia over next 12 to 13 days, resolution of vitritis. However, the vision did not improve because of posterior segment complications and the anterior segment formation of anterior staphyloma and disorganized anterior chamber. This patient, a 64-year-old female who presented to us with painful rash of 10 to 12 days duration, and in addition, she had diplopia and diminution of vision. On examination, she was found to have lateral rectus palsy with abduction deficit, and ocular examination revealed epithelial keratitis. So on further history, it was found that she had taken acyclovir irregularly and also some home remedies. Again, this patient was treated with IV acyclovir and prednisolone after 2 weeks, in addition to local treatment, and she responded to treatment within around 10 days after starting of treatment. this patient, an interesting patient, a 58-year-old male who came to us with complaints of pain, diminution of vision, and redness. He was found to have a 3 millimeter sized depressed lesion with epithelial margins epithelial pulled up at the margin. And he was, in addition, had decreased corneal sensations and decreased Shermer. On evaluation, on a further evaluation, he reported that he was a diagnosed case of HZO and took systemic medication, as well as was prescribed acyclovir 5% and moxifloxacin, which he continued to put because he did not have an improvement in the ocular symptoms. So because of that, he was diagnosed to have a neurotropic keratitis, was later optimized topical treatment. We withdraw all the toxic medications, the acyclovir and moxifloxacin. Patient was started on frequent lubrication and topical steroids. He did EMT and tassoraphy, and he responded to treatment within 2 weeks. So this very clinical spectrum of patient we have seen over last 2 years, and they have, it is like, as I said earlier, that more and more young patients with ocular involvement are seen. About systemic complications, systemic complications are increasingly being seen. It has been
Can't hear you, Dr. Bhavna.
Yes, sir. I think she's gone off.
I think the loss of
Hello?
connection.
Yes. Her screen has gone off and we are on the gallery view.
Maybe the time, I think maybe we've crossed the time limit.
But
No, but
we
we
are all live still, yeah.
Yeah.
Yes.
Is the screen still visible?
Her screen, no, Dr. Bhavna, we can't see your screen. The screen has closed.
There was a technical.
Yeah, the screen sharing has closed.
Yeah, I think there was a technical glitch and I just lost the screen. Is the screen visible now?
You can reshare, doctor.
Yeah, reshare.
Yeah.
Yeah.
Yes, I'll do that.
So while she's resharing, I have a quick question about the usage of both topical as well as systemic antiviral agents in most of your cases. Is that your standard practice for HZO? Because I thought that's a bit of an overkill. When they are on maximum oral antiviral medication to the tune of 800 milligram 5 times a day, is there a need to use the topical approach as well?
Yes, we did use, madam, topical antivirals as well, because these are all the cases which were complicated and which were using, acyclovir from long time and not responding. So there's this series of patients which I'm presenting is a select patients in which we did use. Otherwise, in a normal course, we just give systemic acyclovir or systemic valcyclovir and with topical adjuvant medications.
Right.
Yes. This. Again, I think, is it on the screen slideshow mode? No. Yes.
Any of these people you recommend for vaccination post the incidence of
yes, ma'am. So now, yes, ma'am. So now in our center, we have started to recommend vaccination, madam, because the neurology department and the dermatology department have started to, report that there have been increasing number of VZV after COVID, madam. So now we have started to recommend patients for vaccination, ma'am, which I'll be taking in the subsequent slides.
Thanks, Dr. Babu.
It started from the yes, so there is a risk of CVA cardiac accidents like CAD, MI, and arrhythmias, in addition, chronic immune-mediated vasculopathies and lymphoid malignancies in such cases. So it is very important that we diagnose such cases timely and start them on treatment, not only on treatment, but we keep them on follow-up at least for a year with the ophthalmologist and with the treating physician and neurophysician. And there are CDC recommendations for vaccination in people more than 50 years of age because it reduces the incidence, disease burden, and post-herpetic neuralgia. So there are two vaccines available, the live attenuated zoster vaccine and recombinant adjuvant Shingrix vaccine. For post-exposure prophylaxis, there are recommendations of varicella zoster immunoglobulin or the Varizig. The carry-home message is that since we would not be able to predict who will have serious complications, so it is good that we begin antiviral treatment as soon as possible in adequate dose. Steroids are to be reserved for restricted cases under cover of antiviral agents always. There should be high index of suspicion for herpes zoster sign pigmente because these are the cases who also require antiviral treatment to prevent them for any further complications. The posterior segment evaluation should be mandatorily done in all patients. If you can dilate and see, it is good. Otherwise, B-scan can be done. Follow-up of all patients for 1 year at least with the neurophysician and ophthalmologist, and there is recommendation of sero vaccination to subjects more than 50 years. Thank you very much for the patient hearing, and I regret the technical glitch in the middle of the presentation.
So which is the vaccine you would recommend, Professor Bhavna? The Shingrix or the other one?
The Shingrix has now been recommended, ma'am, because the efficacy is 97% in this, whereas in Zostavax, it is actually a live attenuated vaccine. So the usage also restricted. You have to give the patients it can be given only to patients less than 50 years of age, whereas Shingrix can be given to patients more than 50 years of age also. And also the efficacy is around 60% of Zostavax, whereas Shingrix it is around 97%.
Thank you.
I think an excellent collection of cases, like it is very informative and good. So congratulations on that.
Yes, thank you. I think because we are towards the end of the session, we should take questions from the audience now and stop sharing first and then. Yes. There are a few questions from the audience. Where's the...
Madam, between the valacyclovir and acyclovir for acute herpes, like, do you have any preference over one above the other? Like, since several of the studies which say that valacyclovir is more efficacious and the chances of complications are lesser, and also the patients tend to have lesser of neuralgia, post-herpetic neuralgia with valacyclovir.
Valacyclovir is a little expensive than acyclovir. The advantage is that it is a pro-drug. So the bioavailability of valacyclovir is more, like it is almost 50% more bioavailable than acyclovir. Acyclovir oral absorption is less. So that is why valacyclovir is preferred over acyclovir as found suitable. However, because of the cost constraint, we prefer to give acyclovir.
I think the dermatologists and neurologists, they prefer valacyclovir.
Yes,
and it is easier dosage also. 805 times is more difficult to take than 1 gram TID. So
yes,
I guess it's more compliance also.
Yeah, even they say the chance of post-herpetic neuralgia is also lesser with valacyclovir as compared to acyclovir.
So, Sunil, can you help me in this? I cannot see the chat box where we can see the questions of the audiences.
Meanwhile, I'll just ask Dr. Anubha, you mentioned the conventional PCR. So would you prefer the conventional one or the RT-qPCR or a multiplex PCR for the ACTAP?
So we do conventional PCR routinely, Dr. Vijay, but yeah, if you do a real-time PCR, it would be more more dependable, but it is more expensive and difficult to do on a routine basis.
Okay.
Mostly, the viral diagnosis would be clinical. Only in atypical cases or any doubtful cases we run a PCR.
So any experience with the TF film samples also?
So it has been seen that in HSV cases, particularly endothelitis, aqueous is actually the best sample.
Yes.
So
In
if you go
epithelial
for
keratitis,
TFL,
anterior
yeah,
corneal involvements, in those
correct.
viral shedding is more in the tears. So it has been, I think many studies are there which have mentioned no first-hand experience as such, but tear samples also give a good yield, especially in epithelial keratitis and maybe anterior stromal keratitis.
Yes.
What is your timing of taking this sampling, madam, for suspected viral uveitis, like keratic uveitis?
Timing as in how much time after what? I didn't get your question. I'm sorry.
Usually these are the patients whom like somebody has already started with the oral antivirals and so. So is it beneficial to take the aqueous sample?
Only in
such
suspicious,
patients,
in doubtful cases we'll take, not on a routine basis.
Okay.
Especially aqueous sample is only if you are planning an endothelial keratoplasty, you do not know what caused the endothelial decompensation and you just want to rule out. Especially in a case where differential corneal edema is there, along with other signs of previous herpetic attacks, virus attacks, iris atrophy, etc.
Yeah, I think for PCR, somebody is whether they are on antiviral or not doesn't matter. One thing, and another thing, Dr. Anubha, our UUR specialist quote, even I have gone through that particular article. I don't remember where now, where they treat CMV uveitis with only a topical ganciclovir. And they say the penetration is good as well. So since it's a very expensive treatment, oral ganciclovir or val ganciclovir, they use only the topical. And some of our cases of endotheliitis also, I tried that.
So the recommendation in literature, Dr. Revati, what I also came across was that topical ganciclovir has poorer penetration in comparison to topical acyclovir. They have studied it for herpes. So
okay, this also from the literature I quote.
Yes.
This also from the literature I quote. And, but it is from the uveitis group, not from the corneal group.
Thank you. Yeah.
Dr. Ritu Arora presented few cases of CMV endothelitis, which she treated with topical ganciclovir. Can we have some words from Dr. Ritu?
Ma'am, you are mute, I think.
No, I just had 2 cases of CMV keratitis, and one one recovered and one did not recover. I wouldn't say that,
Because I saw that case you presented in coffee with CFS, and you shared ganciclovir gel along with steroid, and it responded.
Yeah, but then it, few days later, it went into a total corneal edema.
Okay.
Yeah.
We had a case where there was a retinal involvement as well as a CMV endothelitis. So when there was a retinal involvement and then later the endothelitis was there, we said, okay, in retrospect, it could be a CMV endothelitis rather than a HSV. So that was a retrospective kind of thing.
And another thing, post-COVID, I have seen that herpes zoster ophthalmicus have occurred in younger patient, and previously I used to rule out HIV and other causes of immunosuppression. But post-COVID, the other causes of immunosuppression were negative, and they turned out to be just herpes zoster ophthalmicus.
With your permission, yeah.
Yes. And yes, others have the same kind of experience, or?
Even pre-COVID, Pratik, anytime what we learned during fellowship was younger patients, we had to test for HIV, but
yes.
we never found any younger patients with herpes zoster also to have HIV positive. They were
I diagnosed many cases who turned out to be HIV, and they were not knowing they were HIV positive.
Yeah, but we didn't find any of those actually, even pre or post-COVID. We didn't have that experience with the younger lot.
Ma'am, with your permission, I would like to just show a patient of CMV endothelitis, which we came across. Just like to share the picture.
In the meantime, that Dr. Praveen is showing this picture, there's one question from Dr. Gopal Krishna. He's asked, does tacrolimus ointment has any role in viral keratitis? Madam Vanati, does tacrolimus ointment has any role in viral keratitis? And what are the chances of recurrence in the graft? I believe he's asking for the recurrence in the
Recurrence
graft
in grafts,
post-viral scar, yes.
See, tacrolimus ointment is more of an immune modulator, and it's a more effective immune modulating therapy compared to cyclosporin, but its ocular surface toxicity is much higher here. So many of them do not tolerate if you have it instilled into the conjunctival cul-de-sac here. But we have started using tacrolimus 0.1% over the lid application. In fact, it was our paper where we had compared the over the lid application of tacrolimus 0.1% ointment, which did have substantial levels of tear penetration through the skin, and tear levels of tacrolimus were found sufficient. This, of course, we used for chronic VKC patients here, pediatric chronic VKC patients, and we found the resolution of their lid pathologies, their GPC and their chronic papillary conjunctivitis resolved well here. And we have now extended using tacrolimus ointment into our pediatric grafts here, not per se for viral keratitis here. But when you are looking at those instances where there's going to be a higher chance for graft rejections or at high risk for graft rejections, we have started resorting to use of tacrolimus ointment over the lid. But I use it mostly in my pediatric cases and not per se for specifically for viral keratitis. If you're looking at the immune modulating therapies, for the immune modulating effect, because the dry eye effect associated with the viral keratitis, people have suggested using topical cyclosporin in long-term use of viral keratoconjunctivitis cases.
Excellent picture, Praveen.
Yeah.
Very nice picture, huh?
Yes, ma'am. This is actually typical keratic precipitates that we came across. And we treated this patient initially with valcyclovir, and then later he didn't respond. Then we switched over to valcyclovir since patient was affording. He responded very well. Initially, when he presented, his IOPs were in 50s actually, so which is classical of CMV uveitis. And later on, we also did PCR twice, but it turned out to be negative. But clinical picture, very high IOP, was like more towards the CMV endothelitis and uveitis. So he responded well to the treatment.
Posterior segment was okay, what?
Yes, ma'am. Yes, ma'am. Posterior segment was unaffected. Yeah.
But excellent picture, huh? I've seen one ring. I've not seen so many rings.
Yes, I think it's a very classical.
This is a classical front cover page photograph.
Yeah, it's a classical presentation. Very nice, yeah.
I'd also like to share one more picture in which we can see classical dendritic-like keratic precipitates of CMV uveitis also. I'll see if I can find it.
I've also seen just single ring presentations. Sometimes they are very fleeting and they go away by the time the patient comes to you for the next visit, even without treatment. And this is, I think, was highlighted by the Singapore study group that now cytomegalokeratouveitis and endotheliitis need not present only in the immunocompromised and immune competent patients also. Anterior segment involvements of cytomegalovirus can be seen. So it need not necessarily be that they have to have a HIV positivity.
This is another patient, ma'am. So this is the high magnified image in the right side, which you can see the dendritic kind of.
We are still seeing your old picture only, your previous picture.
Okay, I'll just share, ma'am.
I can invite you to share this picture for IGO cover page.
Sure, ma'am. Sure, ma'am. Is it visible, ma'am, now?
Now we can see.
Yes. This is the right side is the magnified image. We can see classical dendritic KPs. This is also same patient, ma'am. He also presented with very high intraocular pressure. And again, he
Or did you
already
get a
lost.
cytomegalovirus positivity in this?
No, no, ma'am. No, ma'am.
You
no.
did not. So it's a presumed CMV.
This is presumed CMV.
Presumed CMV, yeah.
Yes.
So this is a microdendritic keratitis picture with, I think, fresh KPs.
Even the previous one you said was PCR negative, what?
PCR negative, ma'am. Twice we did PCR, but both times it came out
Both
to
of
be
them are clinical diagnosis, right?
Aqueous, is it?
Yes.
For aqueous?
Yes,
Aqueous PCR, yeah.
Aqueous PCR, yeah.
Both were clinically diagnosed, huh?
Both were clinically
Both were
diagnosed.
so you should say it's a presumed diagnosis and not
Presumed.
a confirmed,
Yes, yes.
microbiological confirmed one.
True,
Yeah.
true,
Yeah.
true. But in
Actually,
that case,
Praveen, very similar to your second patient,
Yeah.
we had a case. We had actually published it as a case report in IGO also. The presentation was exactly similar with these kind of, star-studded keratic precipitates branching out in a dendritic manner, the very high IOP, and then the patient had no actual history. It was treated as viral keratitis elsewhere. I don't remember whether it was HSV endothelitis or CMV that he was treated for. And then upon very close examination, it was very difficult to see because there was a little flare and cells in the AC as well. Then we saw a slight breach in the anterior capsule. Then digging deep in the history, there was a vague history of blunt injury. And it was actually a lens protein leak, which was giving rise to this kind of a picture. So why the difference? Because in viral keratitis, you want to quieten the eye and do a cataract surgery. Whereas over there in lens leak, if you wait for quietness, then it goes on, into a vicious cycle. You need to get temporary control of inflammation and uveitis and go ahead with the cataract surgery, which is the treatment. So the treatment is, opposite in both ends of the spectrum. I just wanted to share that case, which looked similar, but actually turned out different. We've put this in IGA.
So
in this case, how would you go about, ma'am? Like twice the PCR was negative, but looking into the clinical picture and the presentation of the patient per se, rest all of the features were fitting into the diagnosis of CMV uveitis in this case.
There's no harm in giving a course of the treatment.
Sure.
So yes, I think we are towards the end of the very insightful session today, and all the talks were very informative. In conclusion, I would just like to say that viral keratitis has a diverse spectrum of presentation. Hence, we should approach each case with a fresh perspective and for a careful diagnosis, and do a careful examination also in addition to a detailed history before starting any treatment, and identify the recurrences on time for appropriate intervention, and because it is crucial not only for therapeutic benefits but also in managing chronicity and optimal use of antiviral drugs in such patients. And I would like to thank now All India Ophthalmic Society, Dr. Samar Kumar Basak and Professor Dr. Santosh Honavar for this novel series on walk-in viral keratitis. And I thank all the speakers who have taken out time and for some informative talks. I thank all the expert panelists for sparing time for this presentation. And I also thank all our chairpersons who have cordially accepted our invite for chairing this session today. And I thank all of you for being with us. I thank Sunil from Messrs. Zadiotech for this flawless conduction of the session. Thank you very much for being part of this session today. Thank you.
Thank you.
Thank you, Dr. Bhavna. Thank you.
Thank you so much.
Thank you, Dr. Bhavna.
Thank you.
It's a privilege to be here.
Thank you.